Yes, sir. We are live now. So it's 3, 2, 1.
Should I
Over to
start?
you, sir.
Hello.
Yes, over to you, sir.
Okay. Good morning, everyone. I, Dr. H.D. Ahir, Professor and Head, Ophthalmology Department, SBK's Medical Institute and Research Center, Sumandip University, Piparia, and Kiraj Hospital. Today, the topic of basics of glaucoma is an online CME. So first, I will introduce the guest speakers and our speaker in brief, and then we will start the session. So first is I will introduce Dr. Khushbu Shah. She is a glaucoma surgeon. Hello. She has done her MBBS at SDU Medical College, Kolar, Karnataka in 2012 and MS Ophthalmology from JN Medical College, Belgaum, Karnataka in 2005. She was gold medalist in the ophthalmology subject in MBBS 2012 and also in the University Gold Medalist in MS Ophthalmology in 2015. She is a FICO in 2015 and FAICO in 2020 with a glaucoma subspecialty. She is a consultant ophthalmologist, cataract and glaucoma surgeon at Dr. Nutan Shah Eye Hospital Private in the Baroda city. She has also worked as Narayan Charitable Trust Hospital as a visiting glaucoma surgeon up to 2020 April. She has also worked as a KV Baba Municipal Hospital, Mumbai, Santi Krupa Charitable Hospital, Deolali, and Vasant Rao Pawar Medical College as an assistant professor from 2016 to 17. She has worked as a senior resident in glaucoma clinic at the NIBH accredited, completely charitable Sri Satya Sai Institute of the Higher Medical Sciences from March 2018 to June 2020. Currently, she is working as a glaucoma consultant surgeon at Baroda Medical College and SSB Hospital, Baroda, KG Patel Children Hospital, Vijay Vallabh Charitable Hospital, and Dr. Nutan Shah Eye Hospital, Private Hospital, Baroda. She is regularly performing the phacoemulsion surgery with foldable IOL, SICS, and glaucoma surgeries of all types like trabeculectomy, depth revision surgery, cyclocryotherapy, glaucoma drainage devices, implantation, etc. And also the base OPD-based procedure like the NDR capsulotomy, retinal photocoagulation, laser iridotomy, selective laser trabeculoplasty. She is expert in the OPD diagnostic procedures like the slit lamp examination, applanation tonometry, indentation tonometry, gonioscopy, and all direct and indirect ophthalmoscopy. Second. I will introduce second speaker, Dr. Paraj Dave. Yes, passed his MBBS from the Pramukh Swami Medical College, Sardar Patel University, Karamsad in 2007. He passed his MS Ophthalmology from the Pramukh Swami Medical College, SP University, Karamsad at 2010. And he has done his long-term glaucoma fellowship at the prestigious L.U. Prasad Eye Institute, Hyderabad from 2012 to 2010 to 2012. Important awards he has received in the Glaucoma Society Award for the best paper in 2012, Glaucoma Society of India Best Video Award in 2012, Glaucoma Society of India Best Paper Award in 2015, All India Ophthalmic Society Best Paper Award in 2015, All India Ophthalmological Society Best Paper in Glaucoma Session in 2017. At present, he is the medical director of the Dave Eye Clinic at Vadodara. And he is the former consultant and head of the glaucoma services at the Dr. T.V. Patel Eye Institute and SET ML Vaduvalla Eye Hospital, Vadodara. He was also the honorary secretary of Baroda Ophthalmic Society from 2014 to 2016 and 2020 to 2022. He is also the faculty of Glaucoma Society of India and assistant editor of Indian Journal of Ophthalmology. The third speaker is Dr. Deep Shah. He has done his ophthalmology, DNB in ophthalmology and FMRF glaucoma at Sankar Nethralaya, Chennai. He passed his MBBS from the Medical College and SSC Hospital, Vadodara in 2012. And he has done his DNB in ophthalmology at Dr. Thakur Bhai V. Patel Eye Institute, Vadodara from 2014 to 2017. And he has Medical Research Foundation, Sankar Nethralaya, Chennai, Ratan Tata Fellowship in phacoemulsification. And also he has done SRCP at the GMARS Medical College, Himmatnagar and Gotri. He has worked as a glaucoma surgeon and cataract consultant in Thakur Bhai V. Patel Eye Institute, Vadodara from April 2021 to the currently he is also at there. He is a visiting surgeon, glaucoma surgeon at the Santram Eye Hospital, Nadiyad. He is a Medical Research Foundation, Sankar Nethralaya. He has performed the Research cum Council Fellow in Department of Glaucoma from April 2018 to March 2020. Fourth speaker is Dr. Sachin Mungale. He has passed his MBBS from 1993 to 99 in Baroda, from Baroda Medical College, MS University. He has passed his MS Ophthalmology from Baroda Medical in 2003. He has done his glaucoma, long-term glaucoma fellowship at LV Prasad Eye Institute, Hyderabad from January 2006 to March 2017. He is working as a glaucoma surgeon at his Mungle Eye Hospital since 2017. And he is a visiting glaucoma consultant from 2010 at Dr. Sachdev Eye Hospital, which is a NABH credited hospital at Surat. He is also the visiting glaucoma consultant at the Asirvad Eye Hospital, Navsari, since 2015. And also is a visiting glaucoma surgeon at Santram Eye Hospital, Nadiyad from 2021. His surgical experience in the cataract surgeries and also with the combined surgeries with the glaucoma and cataract. He is expert in the pediatric and adult both glaucoma surgeries, also performing the valve surgeries. And all kind of glaucoma surgery and lasers he is performing, very sincere and senior glaucoma surgeons. Now, we have our own faculty, Dr. Puneet Singh. He is working as a professor in the Department of Ophthalmology and is also as a glaucoma surgeon specialist at the SBKS MI and RC, Sumandip Hospital and Diraj Hospital, Vagodia. He has passed his MBBS at the KMC Manipal in 2001 to 2006. He passed his MS Ophthalmology from SDU Medical College from 2008 to 2011. He has done the long-term fellowship in the glaucoma from the most prestigious institute of the world, Arvind Eye Institute, Coimbatore, from 2011 to 2013. And he has done his phaco fellowship at the Aresan Eye Hospital, Erode, and medical retina fellowship from the Modern Eye Retinal Center, Nellore. He has also performed done the LASIK fellowship from Dr. Eye Institute, Mumbai. And he is Hmm? Start with. He is also the administrative post of the HRRP as a coordinator. He is the member of the ethics committee at our college. He is a medical nodal officer during the COVID ward, and there are 11 publications in the index journals. He is the guest faculty of glaucoma specialist in the Gujarat Ophthalmic Society conference, which was held in 2016. Also as a guest faculty of Gujarat Ophthalmic Society 2017 at Rajkot, and Gujarat Ophthalmic Society and the guest faculty in 2018 at Ahmedabad. He was also guest faculty of glaucoma specialist in All India Postgraduate Training Program in 2018. He was also the guest faculty at the Glaucoma Symposium organized by the Glaucoma Society of India in 2020 at Vadodara. He is a lifetime member of AIOS, GSI, and GOS. He is the principal investigator for the various glaucoma global clinical trial, currently principal investigator of the 2 glaucoma global clinical trial, ARMD trial for retina. Successfully, he has cleared the US FDA inspection for the glaucoma trial. So, will be benefited from the knowledge, skill, and experience of all these glaucoma surgeons. And I will proceed for this, starting the session.
Good morning, everyone. First of all, again, I would like to welcome you all to the CME on the basics of glaucoma. Before this CME begin, I would like to introduce myself. Myself, Dr. Sujata Charil, working as an assistant professor at Dheeraj Hospital. It's my honor to be a moderator for the CME. So without much ado, I would like to our first faculty, Dr. Khushbu Shah, on a talk on the importance of intraocular pressures. So over to you, ma'am, Dr. Khushbu Shah.
Yeah. Am I audible? Am I audible?
Yes.
You are, yeah, okay.
Especially audible. Please carry on.
Yes, yes, yes. So, good morning, everyone. I'm honored for having been invited to this CME to speak on select topics on glaucoma in the presence of such esteemed faculty. I will try my best to keep this talk to the point, aimed at the residents, and which is clinically relevant. So my topic is the importance of intraocular pressure or tonometry. So intraocular pressure as such physiologically is important to maintain proper functioning of the intraocular tissue, because it is the major factor which drives perfusion. And from the glaucoma point of view, it is the only known modifiable risk factor. So that is the only factor which we can treat for stopping the progression of glaucoma. So tonometry is the clinical technique of measuring this intraocular pressure. And the device which we use to measure it is the tonometer. Now, an ideal tonometer should give us accurate readings and a measurement of IOP which is convenient to use at all times, at all places, in all patients, whether they are they are debilitated, or whether it's a child, or whether a patient is uncooperative and squeezing lids. An ideal tonometer should give us an accurate reading. The reading should not have variability from day to day or from observer to observer. It should have easy maintenance. It should be easy to standardize. Needless to say, we do not have an ideal tonometer right now, but we have a variety of tonometers which are available. And there are tonometers which are a lot more accurate, but are not very easily accessible. So we will keep our discussion to the tonometers which are gold standard and the tonometers which are easily available and right now widespread uses them. So tonometry can broadly be divided as direct and indirect. Direct tonometry is when you enter into the anterior chamber and measure the exact intraocular pressure. That is called as manometry. The other is an indirect tonometry, where we obtain an indirect idea of what the pressure is inside the eye without entering into the eye. This indirect tonometry can either be done by indentation, that is pressing on the cornea and indenting the cornea, or it can be done by applanation, that is making the cornea flat. Applanation tonometry can further be classified as contact and non-contact tonometry, which we will be seeing further. So these indirect methods of applanation tonometry can have a Goldman applanation tonometer, which is a slit lamp mounted tonometer and is the current gold standard in measuring intraocular pressure. A handheld version of this is the Perkins tonometer. We will also see in detail about the non-contact tonometer, which is seen very widespreadly used right now. We also have the tonopen, which is used for its portability, and the ocular response analyzer. Indentation tonometry in the form of Schiot's tonometer is probably the most widespread tonometer currently. And other forms of tonometry which are coming up are the rebound tonometry, which is now being used for screening, as well as it gives a very good correlation with the Goldman tonometer. So a brief word about the direct tonometry or manometry. Here, the anterior chamber, it is an invasive procedure. The anterior chamber is entered with a needle. And then if we can exactly prevent the outflow of the aqueous, that is the exact pressure which is inside the globe. And this is seen by the column of water in mm of mercury. This is, needless to say, not useful for regular patients. It is used for research purposes in cadaveric eyes. One word about digital or tonometry or finger tension, which has been used for a very long time. We have access to many more tonometers now, which give very accurate readings. This at the best can only give us one idea or arbitrary type of reading, where we ask the patient to look down and not close the eyes. And through the tarsal plate, we look for the fluctuation between our two index fingers and look whether the eyeball can be graded as either soft, where it is low intraocular pressure, or firm, which is relatively normal pressure, or hard eyeball, which is a higher intraocular pressure. But this method is not accurate. It cannot give us a proper reading. It cannot be used for follow-ups, and this reading can be grossly erroneous. Schiot's tonometry, as I said, is very commonly used, has been used for a long time also. So this basically consists of a lever system. There is a reading scale over here and a needle which points to the readings. The lever system supports a weight over here, which generally is 5.5 grams. But additionally, we can have weights of 7.5, 10, and 15 grams as well. This is the plunger. This is the foot plate which rests on the cornea, and the plunger indents the cornea, as we can see over here. So this plunger indents the cornea. The fluid is pushed away, the aqueous is pushed away from that area. Now, the principle that we use here is that the force with which this plunger indents the cornea gives us the intraocular pressure, which is not just the pressure which is in the eye, but also the resistance which is offered by the eye or the scleral rigidity. As a result, what readings we get need to be modified according to the arbitrary scleral rigidity which they have selected. So this is given by the Friedenwald's conversion table, where we have readings for different weights, and whatever reading we get, we interpret it by looking at this table. If we get a reading of less than 4, then we have to also look at the higher weights. We have to put higher weights and look at them for more accuracy. The lesser the reading, the more is the intraocular pressure. So here the patient's eye is anesthetized with lignocaine or proparacaine. The patient is always to be kept in a supine position, looking at a fixed target. If the patient makes ocular movements, the intraocular pressure reading can change. And then we have to check, at least 3 readings have to be taken before we, and then the average of those 3 readings is taken as the final reading. Sources of error are many in this. They can be operator related sources, as in the proper pressure is not used. They can be instrument errors, as in calibration is not right. They can be patient related errors, because while doing the procedure, the patient might have moved, there might have been a tight collar, and so on. The most important error, though, comes from variations in the scleral rigidity. This most commonly happens in patients with microphthalmos, high myopia, ophthalmos, and so on. Advantages, though, are that it is a simple technique, it is inexpensive, it is portable, it is widely available, and it is the most widely used tonometer currently. So whether we use it any further, or we acknowledge its use or not, we must know how to interpret it, because there are lots of patients which come with these readings and we have to interpret them. This instrument has to be calibrated at each and every use by putting it on this artificial cornea. And every time when you put it on the surface of the cornea, the reading must come to 0, and then you can use it. If not, then it has to be calibrated again. For sterilizing, either isopropyl alcohol or methylated spirit, hydrogen peroxide can be used. Coming to applanation tonometry, which is currently recommended method of tonometry. Applanation works on the Imbert principle, which states that the pressure inside a perfect sphere, which is ideal, dry, thin-walled, freely, infinitely flexible sphere, the pressure which is applied on this and which is necessary to flatten the surface is equal to the force by the area on which this flattening occurs. Now, cornea is not a perfect sphere. There is difference in the flexibility of the cornea, and then there is a capillary force of the tear film. As a result of it, our measurements of the intraocular pressure by applanation have to be altered based on the capillary force and the flexibility of the cornea. Keeping this in mind, we have two types of applanation tonometers: a fixed force tonometer, where the force is fixed and the applanation area changes, and a fixed area tonometer, where the force remains varying and the applanation area is fixed. So fixed force tonometer is the type, the Maklakov prototype of tonometer. This tonometer is not as commonly used. It differs from the other tonometers that we shall subsequently use. But what is important here is that the applanation area varies in this and the force remains the same. Coming to a fixed area variable type of applanation. This is what we normally practice in the form of Goldman's, Perkins, Dagers, and so on. A Goldman tonometer has a feeler arm which houses this biprism. There is a control for this weight insert here. This is the dial which we rotate and look at the reading at which applanation occurs. And this is the mounting where the slit lamp, on the slit lamp, this device is mounted. So here the force, the area which is applanated is fixed. It is 3.06 mm. This is that area at which the corneal resistance equals the surface tension and negates it out. Inter-observer variability in this case might be a little higher, but intra-observer variability is very good, and as a result, it is a very good tonometer for following up as well. The patient again is anesthetized. The cornea is anesthetized. Patient is mounted on the slit lamp. I'm sorry, I think the resolution of the slides is not very good. Is mounted on the slit lamp, and then after the cornea has been stained, the tear film has been stained, the applanation is performed. So what we look for are these Myers. The two Myers should not be very thick or very thin. Roughly, they are 1/10 of the total age. These two Myers, inner edges should overlap and freely pulsate. That is the ideal reading at which we take. So this shows that there is too much of pressure of applanation and we must reduce the applanation knob. While this shows a far separation and we must increase. When we start applanating, we must start at 1 gram. That is at the reading 1 on the knob. And then we keep increasing it till we get the desired, increasing or decreasing till we get the desired Meyer applanation. The reading is obtained by multiplying it with the reading which we get with a factor of 10. What are the drawbacks of this? The thickness of the cornea changes the reading of the applanation tonometer. So this applanation tonometer is ideally used for cornea of around thickness of 520 micrometers. Anything which is more or less is bound to give us a few variations, but there is no rigid rule by which we can make a correction or a perfect correction factor by which we can correct the intraocular pressure as of now. Thinner corneas will give us falsely low readings. Thicker corneas give falsely high readings. How do we calibrate this? There is a rod which is available with markings for 20 as well as 60 grams, and we calibrate it for 0, 20, and 60. Sterilization can be done either by dipping it in sodium hypochlorite or hydrogen peroxide or isopropyl alcohol solution, or in a busy OPD, it can be done by wiping it with an alcohol swab. A Perkins tonometer comes in handy when the patient cannot be brought on to the slit lamp. So this tonometer can be used for children, for infants, for invalid patients or bedridden patients. So this is how it is done, where there is a plate which rests on the forehead, and then we can applanate. The prism is the same as that in Goldman applanation, and we can look for the readings in the same way as we read the Mayas. The Draeger's tonometer also is a portable type of tonometer. The only thing is that the prisms are different. The next is a tonopen. Tonopen is a flexible device. It is ideal for scarred corneas and for pediatric usage. So this applanates the cornea by making a plunger come in contact with the cornea. This plunger moves inside a disposable sleeve. The applanation of the cornea is recorded by a transducer located at the tip. Since the area of this applanation is lesser than that which is used in the conventional Goldman applanation tonometer, theoretically, the corneal resistance, the area of corneal resistance which is affecting the reading should be less. So this tip is placed on the anesthetized cornea, and multiple readings are taken. These readings come at different confidence levels of 5, 10, and 20%. This is a portable device. It is very good for use for children and for bad. Plus, it comes with a disposable latex cover, so the risk of infection is also minimal. Coming to the non-contact tonometer, which is a non-invasive type of tonometer where a column of air is used to applanate the cornea. Here, the patient is made to sit on this device, put the chin, and then a puff of air is blown onto the cornea. The principle here is that the puff of air creates a force which momentarily flattens the cornea. And this force which is generated is the amount of time which is taken for this to flatten the cornea varies according to the intraocular pressure. And that is how of the intraocular pressure is done by the sensor which is located at the tip. This non-contact tonometer is often very useful when the patient is very apprehensive or the patient is a lid squeezer in children and so on. This also gives a good correlation with the Goldman tonometry in normal pressure ranges. However, at higher pressures, it will not correlate. It also gives false high readings. The Makema tonometer, I shall not discuss in too much detail. This tonometer has also a plunger which is mounted on a rigid spring, and this is used for measuring pressure in eyes with bad corneas or with edematous corneas. It can also be used over soft contact lenses. Next is the rebound tonometer, which is now used quite frequently, especially in busy ophthalmic OPDs. So the rebound tonometer has a support for the head as in a Perkins tonometer. There is a probe which has a steel ball which moves in a magnetic field, and this takes repeated readings which are read out digitally from this screen. This does not require anesthesia. It is very light. And it gives very good correlation with the applanation tonometer. What this does is it kind of indents the cornea, and then the time that the cornea takes to come back and cause deceleration of that steel ball decides the intraocular pressure reading. These readings are also comparable to the GA2. However, this again is not useful for scarred corneas. There is also a tonometry which is transpalpable, where the tonometer is placed over the lid. This reading is of course non-invasive and may be useful in apprehensive patients, but the problem with this is that any scarring in the tarsal plate or lid deformities will give false readings.
Dr. Khushbu, sorry for your interruption, ma'am.
Yes.
But due to shortage of time, can you it a bit faster for your talk?
Wind it up. Yes, sure.
Yes.
Of academic interest
Thank
are
you.
also the dynamic contour tonometer, and these the ocular risk analyzer takes into account the corneal hysteresis. What is important in tonometry is to remember that there are diurnal variations which are normal up to 5 mm of mercury, and there can also be inter and intra-observer variability, but anything more than 8 mm Hg is considered abnormal and we must look for them. We must keep tonometry in, am I audible? Yeah, so we must keep tonometry in perspective, where accurate serial measurement with the same type of tonometers might be more beneficial than infrequent measurements with the best possible tonometer. Sterilizing in between patients is important. We must always look at the complete picture. So patient who is elevating eyes or squeezing the lid fissure or even repeated tonometry can cause error in the reading. Thank you.
Thank you very much, Dr. Khushbu, for your informative talk. Now, our next faculty member is Dr. Paresh Dave. So, I would like to invite him to speak on his first topic, optic disc evaluation, and his second topic, faults and pitfall of perimetry in perimetry.
Okay, am I audible?
So,
Slides are visible. Can I go ahead?
yes, sir. Slides are visible.
Okay, I will also like the technical team to kindly evaluate, kindly see that everyone can write in the chat boxes, because I'll be asking some questions in the end. So kindly enable the chat box for everyone. Thank you. I'll start now. So here we'll see how to correctly evaluate the optic disc for glaucoma. As we all know, optic nerve head evaluation is an important pillar in the management diagnosis of glaucoma, in addition to gonioscopy, tonometry, and perimetry. Now there has been a paradigm shift from everyone harping on the simply on the intraocular pressure to more importance given to the optic nerve head for diagnosis, because we all know that 40% of the axons may be lost in an eye with a normal visual field. So here we will see how to systematically evaluate the optic nerve with the rule called the 5R. So first R is the observing the scleral ring to identify the limit of the optic disc. The second R is to identify the rim. The third R is to examine the retinal nerve fiber layer. The fourth R is to examine the region of parapapillary atrophy, and the fifth R is to look for retinal and optic disc hemorrhages. So let us start with these rules. So rule number 1, observing the scleral ring. So scleral ring appears as a whitish rings which denotes the boundary of the optic nerve head. The average vertical diameter of the optic nerve head is 1.8 and the average horizontal diameter is 1.7 mm. So how to see or how to measure the disc size? So there are two methods. One is with the help of a direct ophthalmoscope, wherein the small aperture of the Welch-Allen direct ophthalmoscope, when you project it into the eye, and if you see that the optic nerve head size is same as the spot of the direct ophthalmoscope, then you are probably dealing with an average size disc. So this is one way of doing it. A more accurate and preferable way of doing it is with a slit lamp biomicroscope, wherein you measure the length of the slit beam, and depending on which lens you are using to visualize the optic nerve head, you have to apply appropriate correction factors. For example, if you're using 90D lens, then whatever value of the optic nerve head diameter you get, you have to multiply it with 1.3 to get the actual values. A small disc is defined as a disc which has a vertical diameter of less than 1.5 mm. A large disc is a disc with a vertical diameter of more than 2.2 mm. The reason why we are interested in noting the optic disc size is because small discs would have a small cup and large discs would have a large cup. Moving on to the second rule, identification of the neuroretinal rim. So rim is basically the distance between the border of the disc and the position where the first order vessels are bending. So this is where they are bending. So this distance between the region between this and this is the optic nerve head rim. So normally the rims follow the ISNT rule, wherein the inferior rim is the thickest, followed by the superior, followed by the nasal, and followed by the temporal rim, which is the thinnest. In large discs, usually the inferior and the superior rims are of equal length. However, the temporal rim continues to be the thinnest. So just to tell you, two terms which are very commonly used when we evaluate the optic nerve. One is notching. So a notch is when there is no residual neuroretinal rim. For example, if you see here in the inferior area, there is no residual rim. Directly, you see the boundary of the optic nerve, no rim present. So this is a notch. Whereas on the other hand here, you see that the glaucomatous process has begun, but there is still some neuroretinal rim left. So this is known as an excavation. So notch and excavation, these are the two terms which we use frequently. Next is you need to see the color of the rim. So whenever you find that the pallor is out of proportion to the cup, you're probably dealing with a non-glaucomatous optic neuropathy, and this needs to be kept in mind. Moving on to the third rule, this is examination of the retinal nerve fiber layer. So nerve fiber layers are seen as bright striations, and we are interested in seeing the supratemporal and infratemporal nerve fiber layer. They are easily seen when you use red-free light. So as you can see here, they appear as bright striations. So we are interested in finding out any localized or focal retinal nerve fiber layer losses. So if you see here, there is this appears as a dark area because the overlying nerve fiber layer is not there. So this region appears darker when you see in a colored setting, and when you use red-free light, it becomes very easy to actually detect focal losses because you can see dark areas in between. So generalized losses are difficult to see, but localized losses are easier because the surrounding RNFL is normal and you are just seeing a focal loss of RNFL, which appears as a dark area. Moving on to the rule number 4 is examining the region of parapapillary atrophy. So you have two zones. One is the outer alpha zone. This is a hyperpigmented or hypopigmented area, and it is seen in both glaucoma and normal individuals. So this is not much of importance. The second is the inner beta zone, and it is caused by the atrophy of the RPE and the choriocapillaries, whereby the underlying choroidal vessels and sclera become visible. This is more common in glaucoma, and also the location correlates with the area of the ongoing glaucomatous damage. So if there is an inferior nerve fiber layer loss, inferior rim loss, you will see a parapapillary atrophy more in inferior area. So this needs to be seen. Moving on to the fifth rule is looking for retinal and optic disc hemorrhage. So basically, disc hemorrhage is any hemorrhage which is present within one disc diameter of the optic nerve head is taken as an optic disc hemorrhage. These are transient and they usually disappear in 2 to 6 months, but they are indicators of ongoing glaucomatous disc damage, and they also have association with RNFL defects. So if there is an inferior disc hemorrhage, inferior notch, and you'll also find an inferior RNFL defect. So again, this is present especially in an area wherein glaucomatous damage is ongoing. So now we'll just go through some examples just to apply what we've just learned. So can I request the team to enable the chat box so that I can have a look as to what are the responses. So basically, let us start with the example. I'll just these are the points that you need to follow. So first is observing the scleral. So I'll tell you the disc size. So this is an average size disc. Now we'll go for the rim. So I'll request everyone to post in the response in the chat box whether this is glaucoma or not, and I'll gradually evaluate and let us see if our responses match. So if as far as the rim goes, I think inferior rim is equal to the superior or slightly lesser than the superior in this case. And if you look at the retinal nerve fiber layer in this region, you will find that the RNFL is not there, and this region appears a little darker because of the loss of RNFL. There is no significant peripapillary atrophy, and there is a disc hemorrhage here. So most likely we are dealing with a case of glaucoma. So this is how we systematically evaluate. Next is, again, I'll say this is an average size disc. So if you look at the neuroretinal rim first, the inferior rim is thicker than the superior, which in turn is thicker than the nasal and temporal. So this is following the ISNT rule. If you look at the nerve fiber layer, nerve fiber looks fine. There are no focal losses, no focal dark areas. If you look for parapapillary atrophy, again you see that there's not much parapapillary atrophy here, and there are no retinal and optic disc hemorrhages. So this is probably a normal disc. Moving on to the next example, say this is an average size disc. If you look at the rim, in this area there is no rim. So this is an area of notching. Again, inferiorly there is again little or no rim. So this is again a notch. If you look for the retinal nerve fiber layer losses, you see here there's a dark area in the superior part and also this area in the inferior part. So there is RNFL loss. Some parapapillary atrophy also visible here, not much, but some, and no optic disc hemorrhage. But so this is probably a glaucomatous disc. Moving on to the fourth example, this is a large size disc. Here the inferior rim is equal to the superior rim, but we have already I already told you that in large size discs this is normal. The inferior and the superior rims are usually equal. If you look at the RNFL again, you see RNFL is absolutely fine. There are no focal losses. Peripapillary atrophy, maybe some here, but not much. And there are no disc hemorrhages. So this is a physiological cup. So this is extremely important because you should not label large physiological cups as being glaucomatous. And last example, again, say this is an average size disc. If you look superiorly, the rim appears not too bad, but inferiorly there is no rim. So here, this is a notch. There is absolutely no rim. And if you look at this area in the RNFL, right from here to here, you see this is a dark area as compared to the other part. So this is an area of RNFL loss, and maybe there is a disc hemorrhage here. So this is a glaucomatous disc. So hope you have learned how to systematically evaluate optic nerve health. And to conclude, I'd like to say cup disc ratio in isolation without mentioning the disc size has no meaning. So next time Dr. Punit, ask you to, tell him how the disc is, always start with the disc size. Just telling, there's a 0.7 cup has no meaning if you don't tell the disc size. And also if you form a habit of carefully examining the optic nerve head, we can obviate the need for expensive gadgets like OCT, GDX, and HRT. So with this, I'd like to conclude the first part of my talk. And with your permission, I'll go to the next talk.
Yes, Varun, please go ahead.
Yeah. Okay, so the next talk is how to interpret the perimetry. So we'll be talking about automated static perimetry, of which Humphrey visual field analyzer is an example. So what is a visual field? Visual field is that portion of the space that is simultaneously visible to the steadily fixating eye. So there are basically two kinds of perimeters. One is kinetic perimetry, in which the stimulus size and the intensity remains the same, but the location changes. So basically what you want to see here is to identify points with the same threshold, or you want to identify the isopters. In static perimetry, on the other hand, the stimulus size and the location will be the same, but the intensity would change, and you test different locations to check for glaucomatous defects. So testing is done along the z-axis, perpendicular to the surface. So this is a photo of an Humphrey visual field, old photo, but even the new machines look similar. So just to tell you some common terms, the stimulus intensity is changed in static perimetries, and the brightest stimulus is 0 decibel, is denoted by 0 decibel, and this will indicate the least amount of sensitivity, because if you need to give a brighter stimulus, the sensitivity is obviously lesser. The dimmest stimulus is denoted by the 50 decibel value, which also denotes the highest sensitivity. So in general, 35 decibel is considered to be normal. The background illumination is also standardized, so it is 31.5 apostops for Humphreys and similar for octopus. So this is standardized, and the stimulus size 3 is most commonly used because we also have a normative database for the same. So what we want to do when we are using Humphrey visual field analyzer is to find the threshold sensitivity of the points at the various locations wherein the points are tested. So threshold sensitivity is defined as the value of the stimulus that is seen 50% of the time at a given location under specific conditions. The commonly used programs for the Humphrey visual field analyzer is 30-2, 24-2, 10-2, and the Macular program. Usually the standard size is Goldman size 3, and we normally prefer using the CETA in versus the full threshold. So the 30-2 program actually tests 76 points, which are 6 degrees apart. The 24-2 program tests a lesser number of points, 54 test points, which are 6 degrees apart. It includes the nasal points, but not the temporal points, and this is faster. So this is an example of a 24-2 CETA standard printout. Next is the 10-2 program. This is used when the defect is more advanced and the central points are involved in the 24-2 program. Here we test 68 points, which are 2 degrees apart, and we have a statistical analysis package also available. So this is how the 10-2 CETA standard looks like. We'll see how to evaluate or interpret each zone in the later part of the talk. Next, you also have the macular program. So wherever you have the central points involved on the 10-2, you should do a macular program. So this tests for advanced field effects. 16 points are tested twice, 5 degrees apart. And if one quadrant records a response of 0, then the patient has split fixation. The importance being, when the patient has split fixation and you want to take him up or her up for surgery, there is a larger or a higher risk of wipeout happening post-surgery. So this is why this is extremely important. So this is how the macular program looks like. If you see here, these are the values that are tested once in, tested twice, one value above and the other value denoted or given in the brackets. And if you see here, in one quadrant, everything is 0. So this patient has split fixation and is at a higher risk of developing wipeout post glaucoma surgery. So full threshold uses a bracketing strategy wherein the machine goes from a non-seeing area, gradually increases the stimulus intensity till the patient sees the stimulus, and then again goes back till the patient does not see the stimulus, and this is how the threshold is calculated. This is basically takes it takes too much time, difficult to perform. In contrast, CETA, which is the full form of which is Swedish Interactive Testing Algorithm. This is a new operating system. This is much faster. So what it does, it paces its tests, and depending on how the patient responds, the surrounding points are adjusted in accordance to how the patient is responding, and testing is started from that point and not from going from the non-seeing to the seeing area. So all this results in a faster test, and it is the next step in testing for visual field effects. So a CETA standard 30-2 would normally take anywhere between 5.5 to 10 minutes. A 30-2 CETA fast or a CETA standard 24-2 would take 3 to 7 minutes, and a CETA fast 24-2 would take 2 to 5 minutes. So ideal is to do a CETA standard 24-2 for most situations. So this is a printout, a modern day printout of the Humphrey Visual Field Analyzer, and these are the things which we will go through one by one. So basically we'll be dividing the printout into 8 zones, and we'll be discussing each zone separately. So we'll start with the zone 1. So zone 1 basically has it has the patient details. So it is important to enter the patient name similarly at every follow-up, because if you don't do so, the machine will take the patient as a different patient, and therefore when the machine wants to calculate, say, progression or wants to give you the data over the multiple visual fields, it will not be able to do so. So every time you enter the name, the same name has to be entered. Next to here, you have the program strategy. Again, you want to stick to the same program strategy. Here you have the vision, the correction, and the pupil diameter. Here, pupil diameter is extremely important. A pupil diameter of less than 2 mm would result in artificial contraction of the visual field, and you don't want that. So patient who is on pilocarpine and has extremely small pupils, it is a good idea to dilate the pupil and then do the visual field test. Next, here you have the date, time, and age. Here is extremely important, because whatever age you enter, the machine is going to compare with the normative database based on that particular age. So if you enter the age wrong, then your comparison would be totally wrong. Next is the zone 2. The zone 2 actually looks into whether the patient has performed the test well or not. So it has the fixation losses, false positives, false negatives, test duration, and foveal threshold. So fixation loss is basically measured with the help of the Heil-Krockow method. So here what the machine does, it first charts the blind spot, and then intermittently it gives stimulus in the region of the blind spot. So we all know that any stimulus in the region of the blind spot, the patient should not be able to see it. So if the patient responds to it, then it indicates that the patient has moved his eye or his or her eye, and then it is marked as a fixation loss. So the implications are, if there is a high fixation loss, it is going to underestimate the glaucomatous field effect. The other way of checking for fixation is with the help of a gaze tracker. Gaze tracker measures the gaze direction for the entire duration of the test. It is sensitive to +1 or -1 degree. An up line indicates a gaze error, whereas a down line indicates situations in which the machine was not able to measure the gaze. So this is an example of exemplary fixation, absolutely steady fixation, and this is how the fixation should be. This is an example where the fixation was good in the beginning, and in this particular region, there were a lot of fixation losses. Then again, the patient could fix properly for the remainder of the duration of the test. This is an example of extremely poor fixation. The top lines indicate fixation losses, and the bottom line indicate situations in which the machine was not able to detect the gaze, which could be due to excessive blinking or a condition like ptosis. Next, you have the reliability indices. So a false positive is when the patient is responding without the machine projecting the stimulus. So this is how it is done. In CETA, false positives are taken when the patient is responding at a faster rate as compared to the normal reaction time. So this is how the CETA takes into consideration a false positive. So implication is that this implies a trigger happy patient, and the patient is just not understanding the test and is just randomly pressing the button or the response button. Next is the false negative rate. So false negative rate is determined by the machine when a patient has responded to a dimmer stimulus but is not responding to a more brighter stimulus at the same point, which is not possible, right? So this is taken as a false negative. The only change in CETA is that this check is usually done at regions where the points are relatively normal. So again, an implication is that this indicates a tiring patient if there is a very high false negative rate. Foveal threshold, if the visual acuity is good but the foveal threshold is low, it may indicate an early damage to the fovea. On the other hand, if the foveal threshold is good and the visual acuity is low, then perhaps the patient needs to be checked for a refraction before the visual test is done, and this visual test may need to be repeated if already done. Moving on to the third zone, this is an area of the grayscale. So not much to see here. We only see two things: white scotomas, which indicates a supra field. Only Superman can do better than normal visual fields. So this indicates a patient who has high false positives. So this can be seen in this area where you have an extremely white looking grayscale. So this is what it is used for. And the other condition is to look for clover leaf defects, wherein the patient was attentive in the beginning, but after that he became tired or simply lost attention and stopped responding to the stimulus. So this is a typical cloverleaf pattern, and this indicates a very high false negative error. Moving on to the next zone, this is the zone 4. So here we have the total deviation, both numerical plots as well as the statistical probability plots. So the total deviation is the point-by-point difference from the expected value for age-related normals. So depending on age, if the patient has done, if the patient's threshold values are poorer, then the values here would be denoted by a minus. Next, you have the area of the pattern standard deviation. So this reveals focal defects after adjusting for the overall sinking or elevation of the hill of vision. So again, you have numerical values and the statistical probability plot. So why do we need a pattern standard deviation plot? This is because if you have generalized depression or elevation, any hidden scotomas would be would not be visible. So in order to unmask them, you need to adjust for generalized depression so that the underlying hidden focal losses can be seen well. So this is done by a statistical method wherein the 7th best point is selected from the total deviation and its threshold is adjusted to 0. And the other deviation of the other points are adjusted accordingly. Causes for diffuse loss or generalized depression are cataract, small pupil, high refractory errors, or uncorrected refractory errors. Moving on to the zone 6, this is an area of the global indices wherein all the information from all the points tested is reduced to single numbers. So here you have the visual field index, VFI, mean deviation, and the pattern standard deviation. Mean deviation is derived from the total deviation plot. So it is a numerical expression of the overall deviation of the visual field from normal. If it is negative, it indicates an infra nature of the field. A positive indicates a supra nature of the field. And you also have pattern standard deviation, which is also derived from the total deviation plot. And this indicates the potholes or the roughness in the hill of vision. Next, the newer machines have something called the visual field index. This represents the entire visual field into a single number, and it's calculated by age-corrected defect depths at the test points identified as significantly depressed in the pattern standard deviation maps. VFI is centrally weighted, more weightage is given to the central point. And in very advanced glaucomas, the pattern standard, instead of the pattern standard deviation, the total deviation probability maps are used to calculate it. So it is given in the form of a percentage, wherein 100% denotes a normal visual field and 0% denotes a perimetrically blind person. And this plot is this is plotted against the patient's age, and this is thought to be lesser affected by media opacities. So this is how it looks like. So you have the value of VFI in terms of percentage, and your patient's age on the axis below. So this can be used for predicting where the patient is likely to go, say after 5 years, if the same slope or deterioration continues. So this is very helpful in giving the patient an idea about the rate of progression. Next, you have the glaucoma hemifield test. We all know that glaucoma, that the hallmark is asymmetry. So what the machine does, machine compares a cluster of points from the superior field to the inferior field and gives you a response depending on how it matches up. So you can have a response like outside normal limit, borderline, generalized depression, or within normal limits. So outside normal limits is important, and it is maybe an indicator of glaucoma. Next, you have, this is the last zone, zone 8, wherein you have the actual threshold values that have been calculated by the machines. So normally you don't need to see this much, but if all zones are normal and there is a high clinical suspicion of glaucoma, this zone may be inspected for any pattern or scotomas. So once you have a visual field, there are 3 questions you need to answer. Is there a field effect? Is it due to glaucoma, and is it progressing or not? So to categorize a visual field effect, it must satisfy the Anderson-Patella criteria. These are the 3 criteria: the PSD or pattern standard deviation for 3 or more non-H points in case full threshold is used, or if CETA standard 24-2 is used, you can also include the H points. They should have a probability of less than 5%, with 1 point having probability of less than 1%, and this should happen in a cluster area where that glaucomatous field effects normally happen. You also should have a pattern standard deviation depressed at a value of P less than 5%, and you should have an abnormal glaucoma hemifield test, and this should be present on 2 successive visual fields. Next, is it due to glaucoma, is something which we'll see now. So this is how a typical cataract looks like. Total deviation would give you these black spots in the statistical probability maps. This is because of generalized depression, and when you see the pattern standard deviation plots, this would disappear. So this is how a typical cataract looks like. A typical glaucoma would have these points on both the total deviation and the pattern standard deviation maps. And if there is both cataract and glaucoma, there will be more spots that you'll see on the total deviation. And when you adjust for generalized depression, there will be few persisting spots which would actually denote the glaucomatous damage, having adjusted for the generalized depression caused by cataract. Learning curve is very, very important because this is a difficult test to do, and the patients may not understand it when they are doing it for the first time. So you should look for the reliability parameters and give the patient some time to understand, and you should repeat the test as and when you feel that the tests have not been done properly. So in this example, you can see how the visual field test dramatically improves at the 4th attempt. So this is a reality, and this needs to be kept in mind. Again, these are the discs, and if you see carefully, there is an inferior RNFL defect here, and when you do visual field test of this patient, you will see a superior nasal step. So an inferior RNFL loss, superior nasal step, both things are correlating. So this is definitely glaucoma. Another example, similar example, inferior RNFL defect, you see a disc hemorrhage here, inferior thinning, and again a superior nasal step. So whenever the disc and the field are correlating, you're obviously dealing with a glaucoma. There can be some artifacts also. One reason is if you use this kind of a trial lens instead of this lenses, which are to be used for perimetries, you can have a rim artifact. So you need to be aware that there are special trial lenses for the perimetry machine. Again, if you just see the perimetry alone, in this case, you see some depressed points around the blind spot, and there are certain paracentral scotomas. But if you see do the good fundus examination, you will find that this is due to parapapillary atrophy. So this is probably not glaucoma. Again, if you just see the visual field here, you'll see an inferior arcuate defect, and you might be tempted to label this patient as having glaucoma. But if you see his retina, you'll find that this is a lasered supratemporal BRVO. Again, if you just see the visual field test, you'll find a superior arcuate defect, but this in fact is caused by an inferior coloboma. So it is extremely important, to correlate the visual field with the nerve, optic nerve, and the retina. Another artifact example is wherein the paler is out of proportion to the cupping. Like you see here, these are large discs. The rims are relatively okay, but the paler is too much. So this is probably a non-glaucomatous optic neuropathy. And if you do a visual field in such patients, this patient had a pituitary tumor, so they'll have the classical bitemporal field effect. So field effects in non-glaucomatous optic neuropathies, usually they respect the vertical meridian as opposed to the glaucomatous field effects, which respect the horizontal meridian. So again, always correlate the retina and the disc findings with the visual field. Last part of the talk is the defect progressing. So this can be done with the help of guided progression analysis, which has two components: the event-based analysis and trend-based analysis. So trend-based analysis is with the help of VFI, which we have already seen. You have the VFI percentage plotted against the age, and with time you can tell the patient, that if similar rate of the similar slope persists after 5 years, you'll probably reach here. So you can explain to the patient whether he's going to be fine or not, and whether you need to step up any treatment if he is rapidly deteriorating. The event-based analysis is the point-wise analysis, wherein the machine will flag 3 or more points which have progressed on 2 or more successive visual fields. So if there are 3 or more points which are progressing based on the EMGT criteria on 2 successive fields, then the machine will label it as possible progression. It will alert you as a possible progression. And if this same happens on 3 successive fields, then the machine will alert you with likely progression. So this is an event-based analysis, and this is a trend-based analysis to check for progression. So to conclude, the take-home message is that Humphrey's visual field is definitely the gold standard. It is the only test which can detect functional damage. There is absolutely no substitute for doing a Humphrey's or any visual field test for that matter. It is extremely robust. It has a good normative data and a progression analysis software. And like always, please correlate with clinical findings. Do not interpret the visual fields in isolation. So with this, I'd like to conclude my talk. Thank you so much for your patient listening. It was a pleasure being here, and I thank Sumandeep, especially Puneet, for this opportunity. Thank you so much.
Thank you very much, sir, for your informative and very interesting talk. And now our next faculty is Dr. Deepsa. I would like to invite him on his topic, update on a medical management of glaucoma and update on a primary angle closure glaucoma. So over to you, Deepsa, doctor.
Good morning, everyone. Am I audible?
Yes, sir, you are audible.
Yeah. Good morning, everyone. I would like to thank Dr. Puneet sir and team for giving me this opportunity. And I'll start with my first talk on update on medical management of glaucoma. As we know, glaucoma is a neurodegenerative disease characterized by progressive loss of retinal ganglion cells and their axons. Lowering of intraocular pressure is currently the only proven treatment strategy for glaucoma. A lot of studies have been done to compare the initial medical management of glaucoma versus initial surgical management. However, related to the risk and complications with anti-glaucoma surgery, medical management remains the topmost management for the glaucoma to initiate with. We have a lot of drugs available with beta blockers having efficacy of around 20 to 25%. Prostaglandin analogs remains most potent drug till date available with reduction of intraocular pressure anywhere between 25 to 35%. It may go to 40% reduction in IOP also. Alpha-2 agonist and topical carbonic anhydrase inhibitors reduces intraocular pressure anywhere between 15 to 25%. Beta blockers predominantly reduces aqueous humor production, while prostaglandin analogs increases uveoscleral outflow. Alpha-2 agonist and carbonic anhydrase inhibitors reduces aqueous humor production. However, alpha-2 agonist also increases some amount of uveoscleral outflow. Tefloprost is one prostaglandin analog which is available in other parts of the country. However, it is not available in Gujarat as of now. It is preservative free. It is also available in a combination with timolol. Comparative studies show similar intraocular pressure reduction as compared with other prostaglandin analog. However, as of now, it is not available in Gujarat. So we have come a long way on for the medical management of glaucoma, from starting with the cholinergic agonist 2 osmotic agents available, oral carbonic anhydrase inhibitors, 2 beta adrenergic antagonists, 2 alpha agonists, 2 topical carbonic anhydrase inhibitor. But major breakthrough was availability of the prostaglandin analog, and it still remains the most important anti-glaucoma medication till date. However, almost after 20 years in 2017, Rho kinase inhibitors got available in the market, and it got FDA approval in 2017, and it got available in India in 2020. 2 Rho kinase inhibitors are available, ripasudil and netarsudil. Let's see how they work. So Rho kinase signaling pathway, it is Rho associated protein kinase. It is responsible for cytoskeletal changes in trabecular meshwork, and it activates contraction of the actinomyosin and promotes extracellular matrix production. It increases cellular adhesion and increases self-stiffness, and thus it will increase the resistance of trabecular meshwork, reduces aqueous humor drainage, and it increases intraocular pressure. So netarsudil works at the level of the trabecular meshwork, which is the most significant site in case of glaucoma, because increase in the resistance is seen at the level of the trabecular meshwork. So netarsudil will reduce the cytoskeletal changes in the trabecular meshwork, thus leads to reducing the resistance of trabecular pathway and increases the aqueous humor drainage. However, netarsudil also acts on the inhibiting norepinephrine transporter. It increases the availability of the norepinephrine. Norepinephrine causes vasoconstriction, thus lowers blood flow to ciliary processes, lowers aqueous humor production, and thus reduces intraocular pressure. Because of the vasoconstriction, it also reduces episcleral venous pressure and thus lowers intraocular pressure. So netarsudil has multiple mechanisms of actions by which it reduces intraocular pressure. A lot of studies have been done to compare netarsudil with other available anti-glaucoma medication, Rocket 1, Rocket 2, Rocket 4. All these 3 studies compare netarsudil with beta blockers, timolol, whether it is more efficacious than the beta blocker or not. And short-term and long-term results have shown that netarsudil is more efficacious and reduces higher amount of intraocular pressure compared to beta blocker. However, one study has been done which compares netarsudil with prostaglandin analog, and it indicates that it is less efficacious than prostaglandin, which is available as of now. Netarsudil is also available as a combination therapy, for which Mercury 1 and Mercury 2 studies have been done. With a duration of 12 months and 3 months. In both the studies, they have shown that netarsudil latanoprost combination is more efficacious than netarsudil alone and latanoprost alone. However, conjunctival hyperemia is more with combination therapy. So netarsudil 0.02% and ripasudil 0.4%. Netarsudil is available in United States and Europe. However, ripasudil is available in India. Netarsudil has multiple mechanism of action, as we saw. It has a ROCK inhibitor and norepinephrine transporter inhibition. It is the dosing of netarsudil is once at night. However, ripasudil has to be used twice a day. Any glaucoma medication which we use comes with some amount of side effect, and most common side effect is hyperemia. It is less with beta blockers, alpha agonists, more with prostaglandin, and highest with the ROCK inhibitors. And it is even more if you go for ROCK inhibitors with combination therapy with latanoprost. So the medical management of glaucoma, prostaglandin analog remains to be the drug of choice unless and until it is contraindicated in case of uveitic patient. Beta blocker is a second line of therapy unless it is contraindicated, such as in the case of asthmatic patient. Alpha 2 agonist and carbonic anhydrase inhibitors can be used as a third and fourth line of management. As of now, Rho kinase inhibitors come. Rho kinase inhibitors come as the last line in the treatment of glaucoma, mainly because of the side effects they have. Most commonly, hyperemia. So whenever you are using Rho kinase inhibitors, you have to explain to the patient that you will have some amount of congestion. Otherwise, next day only patient will come back to your OPD and tell you that because of starting this drug, I am having this congestion. Other novel IOP lowering medications are nitric oxide donating prostaglandin analog, latanoprostene bunod. However, it is not available in India. And another is Rho kinase inhibitor, latanoprost combination therapy. Future trends in glaucoma therapy looks promising. Sustained drug delivery systems, bimatoprost SR is biodegradable implant which is injected in the anterior chamber and it slowly releases bimatoprost over a period of time. Topical bimatoprost ocular insert is also available, which we have to put in the superior and inferior fornix, and that from that ring slowly drug releases. Travoprost extended release as a biodegradable intracameral implant is also available. Intracanalular insert of sustained release travoprost is also available. However, these are not available in the market. They are still under research, and we'll have to see how many of these drugs come in the market. So, sir, if you allow, I'll go with the second talk.
Yes, Dr. Deep, please carry on. Go ahead with the second talk.
Okay, sir. So my second talk is primary angle closure glaucoma. It is the leading cause of irreversible blindness worldwide. Let's see what are the types of glaucoma. Depending upon the status of the angle, we can classify it in open angle glaucoma or angle closure glaucoma. And again, it can be further divided into primary open angle glaucoma, secondary open angle glaucoma, or primary angle closure glaucoma and secondary angle closure glaucoma, depending upon the causes. If it is idiopathic, it comes under primary, and if you find any cause, it goes under secondary. So this table is very important. Primary angle closure disease is a spectrum, and under this spectrum, there are three variants. Primary angle closure suspect, primary angle closure, and primary angle closure glaucoma. This needs to be defined and classified depending upon the three parameters: whether there is greater than or 180 degree of iridotrabecular contact, elevated intraocular pressure, and or presence of peripheral anterior synechia, and glaucomatous optic neuropathy. So if you have only greater than or equal to 180 degree of iridotrabecular contact, then it comes under primary angle closure suspect. Along with this, if you are seeing elevated intraocular pressure, or even there is presence of one peripheral anterior synechia without any glaucomatous optic neuropathy, it comes under primary angle closure. And if you see glaucomatous optic changes, then it directly goes into primary angle closure glaucoma. So usually, practically, we use Von Erich technique or gonioscopy to diagnose whether it is open angle or close angle. In Von Erich technique, we take peripheral anterior chamber depth and we compare it with the slit corneal thickness of the peripheral cornea and see whether it is what is the depth of the peripheral anterior chamber. If it is greater than 2/3 of the thickness of the peripheral anterior cornea, it is usually open. Like in this case, if you see, this is the slit corneal thickness, and if you compare it, this is the peripheral anterior corneal chamber depth. It is almost greater than 2/3 of the thickness of the cornea, so it should be open. While if it is less than 1/4 of the thickness of the peripheral cornea, it is usually closed. However, Von Erich technique is very subjective, and there is higher chances of false positive results and diagnosis more amount of angle closure glaucomas. So I would suggest that gonioscopy has to be done in all the cases. If you are dealing with glaucoma, we should not classify just on the basis of Von Erich. 4-mirror gonioscope and nowadays 6-mirror gonioscopes are available. If you see iridotrabecular contact, then indentation gonioscopy has to be done to check whether the angles are opening on compression, whether there are synechia present or not. Sir will explain gonioscopy in detail. This is the image of the gonioscopy. You see trabecular meshwork, scleral spur. This is the root of the iris. Newer techniques which are available to diagnose open angle and close angles are anterior segment OCT or ultrasound biomicroscopy. This is the picture showing peripheral iridotrabecular contact. and showing that the angles are closed. ASOCT picture. This ASOCT picture shows partial peripheral iridotomy. This is the picture showing it is complete and gush of fluid coming in the anterior chamber and pigments are present in the anterior chamber. Ultrasound biomicroscopy is very useful when you are suspecting anything behind iris, ciliary body tumors, which we are not able to see. ASOCT cannot penetrate iris. So in such cases, we have to go for the ultrasound biomicroscopy. As in this case, iris bombay is seen on ultrasound biomicroscopy, iris cyst on UBM. So these are the newer techniques which we can use to diagnose angle closure glaucomas and to check whether any other causes are present for the angle closure. So how do we treat primary angle closure disease? As we saw, primary angle closure suspect need not require peripheral iridotomy. Routine follow-up should be enough. Periodic gonioscopy has to be done. But on periodic gonioscopy, if patient converts into PAC or PACG, then we have to go for the YAG peripheral iridotomy. However, in case of PACS, consider YAG PI whenever patient is not able to come for the routine follow-up. Patient is one-eyed. Patient has primary angle closure glaucoma in other eye, and there is a strong family history of glaucoma. In case of primary angle closure glaucoma, medical management, YAG peripheral iridotomy. Lens extraction is a new concept. I will talk about it. Anterior and anti-glaucoma surgery are the treatment of choice in primary angle closure glaucoma. YAG PI, medical management, and usually if pressure doesn't come under control with medical management and YAG PI, anti-glaucoma surgery is required. So these are the treatment options available. As we saw, lens extraction, one thing is goniosynechiolysis, with or without lens extraction can be done. And in end cases, cyclophotocoagulation can also be done. So this is the patient who had angle closure glaucoma and required peripheral iridotomy. As you can see that these are the areas of crypts. These crypts also go till the periphery, but we are not able to see because of the presence of the arcus. So you have to look for the crypts. If you try to do PI at the level of the crypt, these are the thinnest areas available, and you will have to use less amount of energy. So we have to use Abraham iridectomy YAG lenses for doing PI. PI should not be done without lenses. This 66 diopter inner button will give you concentrated energy at one point and reduces your amount of energy used for doing peripheral iridotomy. If you have Zeiss machine for YAG, then you will have this console. This is very important. You have to keep this posterior focus while doing peripheral iridotomy. You can start with the energy of 2 millijoule. If your machine is good, 2 millijoule is enough. However, sometimes you have to go beyond 3 millijoules also if your iris is thick. And size of the aim beam should be kept between 4 to 6. It increases your visualization of the aim beam. So this is the picture of the same patient. This is the peripheral iridotomy that I have done. And one thing we have to do peripheral iridotomy in periphery, as much periphery as possible, because usually the pupillary block is at the level of the mid iris. So doing PI here or here might not help. So it has to be done in the periphery as possible. Eagle study was done in United Kingdom, and they have compared clear lens extraction with the conservative management in case of primary angle closure and primary angle closure glaucoma, and they have found that clear lens extraction showed greater efficacy and was more cost effective than laser peripheral iridotomy. However, this study was based in United Kingdom, and their primary aim is to find cost effectiveness between two treatments available. So for our Indian scenarios, this might not be true. In India, the conservative management still remains the topmost. One interesting case I wanted to show in the end, there was 35 years old female who is one-eyed. other eye loss during childhood. She doesn't remember how it happened. She came to us 4 months back for the routine checkup, and during that time, angles were open and the intraocular pressure was normal. She came to us this month with angle closure glaucoma attack, and she was saying that she was using oral contraceptive pills for 5 days. So we thought of drug-induced angle closure glaucoma. Usual mechanism of action is pupillary block and forward displacement of lens iris diaphragm. These are the drug classes which can cause drug-induced angle closure glaucoma. However, the drug which this patient was using doesn't fall under this category. So we had our suspicious, but peripheral YAG PI had to be done, and we did that. And on the follow-up with 2 anti-glaucoma medications, patient was having pressure of 12 millimeters of mercury post PI. However, on 1 month follow-up, patient presented with this picture. Her clear lens was in anterior chamber. PI, as you can see, it was patent. It is not in the periphery, but when patient presented to us, she had corneal edema. It was very difficult, and she was one-eyed. I had to do something. So PI was done in the mid-periphery. However, patient was lucky this time because the clear lens is completely blocking the pupil. But because of the patent peripheral iridotomy, her pressure was absolutely normal. She didn't have complaint when she came, but when we examined, her lens was in anterior chamber. So retrospectively, if we think now, it was subluxated lens which was causing pupillary block, and ultimately it came in the anterior chamber. She underwent lensectomy, and right now she is aphakic. So different types of situations can occur while treating glaucoma, and we have to take help of all the management, all the types of management which are available during the treatment of such types of glaucoma. Thank you.
Thank you very much, Dr. Deep. Now, next I would like to invite Dr. Puneet Singh to speak on his first topic, gonioscopy. Sir, over to you, sir.
Yes, good morning, everyone. Am I audible? Sujata, am I audible?
Yes, sir. Yes, sir. You are audible.
Okay. So, Sujata, please interrupt me if I exceed my time limits. Okay. And
okay, sir.
For the delay, I'd like to start my topic. So, my topic for today is gonioscopy. And just now, Dr. Deep has spoken about primary angle closure glaucoma. We all know that globally, primary open angle glaucoma is the commonest type of glaucoma, but in Asian populations and Indian scenario, primary angle closure glaucoma is as common as primary open angle glaucoma, and that we can only differentiate when we do gonioscopy. If we do not do gonioscopy, then it is very difficult to differentiate open angle and angle closure. And the most important, the incidence of blindness is more common in angle closure than open angle. That's why gonioscopy plays a very important role in glaucoma diagnosis. So that is a very simple technique to view the most inaccessible structure in the eye. Anterior chamber angle assessment remains the gold standard to manage primary angle closure spectrum glaucoma, which is the major form in Asian populations in our country. Early detection is of paramount importance as we can do laser PI and follow the natural course of the disease. Now, the principle of gonioscopy, what happens, light which comes from the angle of anterior chamber undergoes total internal reflections at the cornea air interface. So what we do when we place the gonio mirror and place it over the cornea, it eliminates the total internal reflection and allows us to view the angle of anterior chamber. We have to keep in our mind in certain conditions where we have a very steep iris like keratoconus, keratoglobus, we can view the angle structure without keeping gonioscopy because of the more steep configuration. Then coming to the different types of gonioscopy, we have two types, direct and indirect. Direct gonioscopy basically used for the diagnostic purpose, and in case of congenital glaucoma, where we have Coupage and Swan Jacobs. And indirect gonioscopy basically used for the adult and glaucoma to differentiate between primary open angle and angle closure glaucoma. Now, this is a picture where we can see the direct gonioscopy is been performed in the OR, operation theater. And the first picture, we are using Kopage lens to for the diagnostic purpose, like in case of examination anesthesia. And the second picture, the Swan Jacob gonio mirror is used, that basically we use for the surgical purpose in terms of goniotomy and trabeculotomy in case of congenital glaucoma. Then coming to direct gonioscopy, we have different instruments. Direct gonioscopy is a little bit cumbersome because unlike indirect, we have to rely on portable slit lamp that can be only done in operation theater. So that is slightly cumbersome. We have two types of direct gonioscopy: Kopage, which is without handle and used for diagnostic, and we have Swan Jacobs, which comes with the handle, basically used for the surgical purpose like goniotomy and trabeculotomy in congenital glaucoma. Then coming to the advantages of direct gonioscopy, there are so many advantages. I would just like to skip the theoretical part. All the residents can go through in the textbooks. Then the disadvantage, it is, as we said, it is not very convenient because we need to depend on the some equipments. Then the most thoroughly discussed topic is indirect gonioscopy, which all of us use in our routine practice. We have two types of indirect gonioscopy: scleral type, which has a larger diameter of contact, like Goldman 1 mirror, 2 mirror, and 3 mirror. Since the diameter of contact is slightly larger at 12 millimeter, so we have to use coupling fluid to see the angle structures. And the technique of doing this kind of gonioscopy, we call it manipulative gonioscopy. In case of corneal type, the diameter of contact is slightly smaller than the cornea, so we don't have to use any kind of coupling fluid. And the technique which we use in case of corneal type is indentation type of gonioscopy. Now we have different indirect gonioscopy like Goldman single mirror, 2 mirror, 3 mirror, where we need to use coupling fluids. Zeiss 4 mirror, Posner, Sussmans are type of corneal type of mirror. Then we have, as we discussed, direct, Kopage, Swan Jacobs. Coming to the advantages of indirect, it is preferred by most because it is can be performed in the OPD and it is quick and convenient method. No special equipments required like a portable slit lamp. We can do on the routine slit lamp with the different illuminations and magnification. Most important thing, we should know how to create a corneal wedge, which we'll see in the next couple of slides, which will help you to differentiate between false open angle and angle closure. Also helps us to differentiate between aberration closure and cynical angle closure in case of angle closure. Disadvantages, normally you see the mirror image. In direct, we see the direct image. In indirect, we see the inverted image. So when you are trying to look at the superior mirror, actually you are seeing the inferior angle, and vice versa. When you are seeing the inferior mirror, you are actually looking at the superior angle. Sometimes mirror image can be confusing, and when you apply a slightly inadvertent pressure over the cornea, okay, using Goldman's mirror, you may falsely narrow the angle structures. While in contrast, we're using Zeiss or Posner's 4 mirror, which is type of indentation gonioscopy, we can falsely open the angle structure and we can falsely miss the angle closure glaucoma. Now, there are certain gonio prism which requires coupling fluid, like Goldman single mirror, 2 mirror, 3 mirror. And there are certain gonio prism which are type of corneal prism which doesn't require coupling fluid because of the smaller diameter, like Zeiss, Posner, Sussmans. This is a picture of Posner. It's a modification of Zeiss with the handle used for the corneal type of gonioscopy. This is a picture of Sussmans, which is again a modified type of Zeiss prism, comes without handle, and this is preferred compared to the Posner because when you use Posners with the handle, as a beginner, you try to indent pressure over the cornea, and you can still level the false open angle, even though it is a case of PSCS or PSCJ because of slightly inverting pressure over the cornea. So we also have 6 mirror gonio prism, which is one of the latest advantages in gonioscopy. Here, what we can we can see all the angles structure at one go without rotation. When we use 4 mirror, we can see the 3 angles at one go, but if you want to see the 4th angle, you have to slightly tilt the gonio prism. And sometimes, as a beginner, you may the technique of the most important thing, the rooms should be darker. Then the height and width of the slit lamp should be minimum 2 to 3, and starts with the inferior angle. So starts with the superior mirror, and when you are crossing the joystick, try to eliminate the light should not follow the Peabody margin. Otherwise, people will get constricted, and we may miss angle closure. So this is a technique of indirect gonioscopy where we use Goldman's mirror, Goldman types of mirror, 3 mirror, and we have to use coupling fluid. Then indirect gonioscopy with the help of 4 mirror, we don't use coupling fluid because the diameter of the contact is smaller than the cornea. And obviously, this will be more useful in case of angle closure where we can differentiate between appositional closure and cynical closure with the help of 4 mirror lens. This is a type of Sussman lens without handle. As I said, this is more comfortable for all of us because it comes without handle and you can still have a stable hands on. Then the important, structure when you do gonioscopy is identification of corneal wedge. What we have to do, we have to make a slit of the slit lamp, make a 30-degree angulation. And when you make a 30-degree angulation, you see 2 lights coming from, one from the epithelial surface, which is the thicker light, and second from the inner surface, which will be the thinner light. The point where the 2 lights meets, that is the termination of decimal moment, which is Schwalbe line. And if you see the angle structures below that means it's open angle. And if you see the light is falling above that means it's angle closure. So if you see the picture above, at the first go, we can just misdiagnose this case as a open angle because those false pigmentation appears like a trabecular meshwork. But when you make a corneal wedge, you see the light is falling below that pigmented line. So the line where it is falling, that is actually a Schwalbe line. So that means the pigmented line is not a trabecular meshwork, that is Sampolsky line, and it is a case of angle closure, which normally sometimes we misdiagnose as open angle. Again, another picture where when you try to make a corneal wedge, the light is falling below the pigmented line, which is again at the first go we may misdiagnose as open angle, considering the pigmented line as a trabecular meshwork, which is actually a case of angle closure. That is the reason behind we still, even though we do gonioscopy, but many times we miss angle closure because of lack of corneal wedge technique. Now, the important technique which we do with the help of Goldman's mirror is manipulative gonioscopy. Sometimes when the cornea is convex, at the primary position we see hydrotrabecular contact, but when we try to tilt the gonio mirror or you want to see the angle structure, or when you ask the patient to look towards the mirror, you see the opening of the angle structure, which is a type of manipulative gonioscopy. And if you see the picture, the primary position, it is closed angle. You can see hydrotrabecular contact. But after doing manipulative gonioscopy, angle gets open up. So it is a type of open angle. Second picture, again, you see primary position, it is a closed angle because of convex iris. After doing manipulative gonioscopy, angle gets open up. So that is the importance of manipulative gonioscopy. Sometimes when you do manipulative gonioscopy and angle still doesn't get open up, then you need to use the Zeiss foam mirror, and you have to apply the pressure with the cornea, and if angles are not opening in spite of applying pressure with the Zeiss foam mirror, that is a type of cynical closure, and if it gets open up with the corneal mirror, that is the type of appositional closure. Now, indirect gonioscopy we have already explained. There is important technique which is called indentation gonioscopy, where what happens when you use Zeiss or Postman's or Sussman's foam mirror and you apply slight pressure of the cornea, because of aqueous gets displaced, we see the opening of the angle structure. So that is a very important technique to differentiate between appositional closure or cynical closure. Now, this is another important technique where we can differentiate and diagnose plateau iris, where when we do indentation gonioscopy, we see S-shaped curvature of the iris. Now, once you done with your gonioscopy, it is very important to draw your gonioscopy finding. We call it goniogram. Personally, there are so many classifications given in the textbook, like Becker-Schaeffer, Shears classifications, RP centers, Speth classifications. But personally, what we recommend, you see and draw the posterior most structure which you see on the gonioscope. Suppose you can see the trabecular meshwork, which is the posterior most structure seen on the superior angle. You write TM, and if you see the scleral spur at the inferior angle, write SS. And instead of writing 3, because 3 can be open angle in Becker-Schaeffer, and it can be closed angle in Shears classification. So instead of writing numerical value 1, 2, 3, 4, it's better to write the posterior most structure seen in each quadrant, which will give us clear picture for anyone, the another person also who is going to see your goniogram. We also have to write the iris configuration, trabecular pigmentations, and manipulative gonioscopy or indentation gonioscopy, whichever gonioscopy we have used. Now, when you do gonioscopy, there are certain things we have to keep in your mind. The first and most important is whether the angle structures are visible. We can see trabecular meshwork and scleral spur in more than 2 quadrants. That means it's open angle. Then once you need to see what are the extent of hydrotrabecular contact. If the iris touches the trabecular meshwork or not, and if it is touching the trabecular meshwork, how much is the the configuration, more than 180 degree or more than 270 degree. If not, if it is not touching the trabecular meshwork, then what is the patient is having previous hydrotrabecular contact. That will come to know with the help of pigments. If there is a contact, then whether it is reversible or not, that will help us to differentiate between apposition closure and synovial closure. Then we also have to need to see the amount of angle pigmentation, which will help us to differentiate between pseudoexfoliations, pigmentary glaucoma. We need to see the iris configuration, which will help us again about convex iris or concave iris, which you normally see in post-op cases or in case of pigmentary glaucoma. Then we need to find out very important thing, NPI, new vessels in case of diabetic PDR or CRB or BRBO. Then we need to see prominent iris processes or anterior displaced valve line. We also need to find out patency of trabecular ostium, any implants, the neotechnic glaucoma implants. Then other miscellaneous conditions like K frame in case of Wilson disease and in case of therapeutic usage. So, pictures for the case open all the four angles. These pictures, we can definitely when you do colonoscopy, this is you can see all four angle structures visible. This is a picture of open angle. Then we have to see this picture, like do we have any PAS, peripheral anterior synechiae? You can see nicely there's a hydrotrabecular contact with some kind of peripheral anterior synechiae in the superior quadrant. Then this picture we'll see some pigments, coarse pigments, which will give us an idea patient might have had some previous acute attack of angle closure, and they may have that is the indication of doing laser PI. Then if the angle is closed, what are the obstructions and how much is the obstructions? Like you can see here, there is a picture of complete hydrotrabecular contact, and that will obviously give you a clue to do laser PI, and other things you have to also look for that, like IOP and other parameters before you decide PI. Then you need to see the band of pigments, trabecular meshwork. You have to see the corneal wedge, which we discussed. That is the most important thing. If you see the picture, primary position looks like an open angle because of pseudopigmentation, but when you try to make a corneal wedge, it is falling behind the pigments. So basically, it's a closed angle, and which is falsely leveled as an open angle. Again, here primary position because of pseudopigmentations, we level them as an open angle case, which is actually once you make a corneal wedge and see the light which is falling beneath that, which is again it's a case of angle closure missed as an open angle. Same thing here, looks like an open angle because of pseudopigmentation, but after making corneal wedge, actually it's a case of angle closure. Similar picture with the pseudopigmentations appears to be open angle, but when you make a corneal wedge technique, it will fall into angle category. Now we have to look for the angle pigmentations. These are the thickly, heavily pigmented trabecular meshwork. Will give us idea and clue. This could be a case of pseudo-exfoliation glaucoma or pigmentary glaucoma. Then again, the similar picture with heavy pigmented trabecular meshwork. It could be a case of pseudo-exfoliation glaucoma or pigmentary glaucoma. Then we need to see for the iris configuration. Convex iris, sometimes we have to perform manipulative gonioscopy to differentiate. And then in pseudophakic eye or pigmentary glaucoma, you have to see for the concave iris configuration. Then once you see the hydrotrabecular contact, we need to differentiate between apposition closure versus synovial closure. This is primary position, angle is supposed to be closed. When you do indentation gonioscopy, you can see trabecular meshwork. So it's a type of angle closure, which is a category of apposition closure. And after doing indentation gonioscopy, if you cannot see trabecular meshwork, that means it's a synovial closure. Then we also need to see anterior segment dysgenesis in the form of angle recession syndrome or eye syndrome. This is a picture of anterior segment dysgenesis, angle recession AR syndrome with a broad posterior phase synechiae touching the hydrotrabecular contact. Again, this is a picture of eye syndrome with the multiple iris processes and multiple peripheral anterior synechiae. This is a picture of eye syndrome, Cogan syndrome with the multiple iris pigments, and we can differentiate with the help of gonio mirror. This is a picture of ostium which is patent, and that we have to perform in any when you do trabeculectomy and when the IOP is not getting under control and the bleb appears to be flat, then we need to perform a gonioscopy to find out the ostium, whether it is patent or not. Sometimes ostium gets blocked with the help of iris tissue or some vitreous. So we need to do Yag laser vitreolysis, and that is a very important tool to find out about the ostium patency. Again, the picture of cyclodialysis cleft, which happens post trauma. Then we need to also differentiate between prominent iris processes versus peripheral anterior synechia. This is a picture of prominent iris processes which is present in the superior 90-degree quadrant. This is again a picture of prominent iris processes which will not cross the scleral spur, and it will be thin and zigzag manner. This is a picture of peripheral anterior synechia, which is a thick and broad base, which will actually cross the scleral spur. So the difference between iris process and synechia: iris process will be fine in structures, synechia will be broad based. Iris process will extend to scleral spur and it will move with indentation. Synechia will be resist any movement and that will extend beyond the scleral spur. So this is a picture of new vessels over the iris, which we normally very important tool to differentiate between NVG that we should perform in all cases of PDR and new vessels. Again, the difference between new vessels and normal vessels will appear thick, new vessels will be fine, averaging, and that will cross the scleral spur. Normal vessels will not cross the scleral spur. So to conclude that, if you see the elephant, that is the actual burden of angle closure in our country, and all the people lying over the elephant are the blind person who doesn't do gonioscopy, and they are clueless about the spectrum of angle closure. So to conclude, gonioscopy is a must for all of us. All of them must do gonioscopy before they treat any type of glaucoma, before they talk any type of glaucoma. For beginners, gonioscopy requires a coupling fluid with lesser price can be considered, because initially when you're doing gonioscopy, you need to have a stable hand, which we can do with Goldman's mirror, and eventually it will worthwhile shifting to gonioscopy without coupling fluid or for the EG and quick procedure. And it can be one-time investment, so better one with the good optics should be considered, and we always advise to go for 4 mirror. Thank you for your kind attention.
Thank you very much for your informative, interesting talk, sir. Now our next faculty is Dr. Khushbu Shah. So I would like to invite her to on a second talk on an approach on a glaucoma suspect. Dr. Khushbu Shah, ma'am, over to you, ma'am.
Thank you. Just a minute, I'll share my screen. So, my topic is approach to a glaucoma suspect. Am I audible clearly?
Yes, ma'am. You are audible.
Okay, thank you. Thank you. Yes. So we typically define glaucoma as a characteristic optic neuropathy caused by raised intraocular pressure with characteristic optic disc changes and visual field changes. So when we have all these three available findings, abnormal findings in all three of them, the diagnosis of glaucoma is pretty clear. The problem arises when all of the findings are not correlating with a diagnosis of glaucoma, but we have some of the findings. For example, a raised intraocular pressure in the absence of optic disc changes or visual field changes, or a disc which shows glaucomatous changes but does not correlate on visual field, or visual field changes suggestive of glaucoma but not with the same intraocular pressure, rise in intraocular pressure. So they are controversial clinical dilemmas. And these individuals, they do have certain risk factors, but not all of them to classify them as glaucoma. So based on what abnormalities are there, the suspects can be based on suspects due to raised intraocular pressure. They will be classified as ocular hypertensives. The ones which have optic nerve head changes, but not the other findings, so they will be classified as disc suspects or visual field suspects. Ones who have abnormal angles and who have a strong family history of glaucoma, with or without a few of the other factors. So why are all suspects treated if there and if we know that it's a progressive optic neuropathy which eventually can claim vision, why not just treat every suspect? Because glaucoma is a chronic and lifelong condition. The treatment for it is chronic or lifelong. It has an impact on the quality of life. There are medication-related side effects. There are economic impacts and lifestyle changes. So we are burdening the patient in case we are overdiagnosing or overtreating glaucoma. So beginning with suspects who have a high intraocular pressure or ocular hypertension. So classically, it is defined as when the intraocular pressure is more than 22 millimeters of mercury. When we say that, we mean it has to be that at least on 2 or more visits, and we have to eliminate all the errors related with tonometry. So it should not be because of some error on the part of doing tonometry, but when there is an accurate reading of 22 or more, but without any other correlating defects in the optic disc or visual field. So in the absence of other features of glaucoma, if we find this, then we label it as an ocular hypertension. So we, as I told you, we have to eliminate other factors like an uncooperative patient or a tight necktie or uncalibrated tonometers or confounding factors. Now, if we have labeled the patient as an ocular hypertensive, then we must be sure that it is only that and not glaucoma. So we must take serial IOP measurements at few other visits at different points of time so that we do not miss any diurnal variations. We must do a thorough and accurate gonioscopy. Optic disc imaging, if possible, is desirable, but if not, then at least a good drawn picture also would suffice. And an optic disc evaluation and documentation is a lot more important in such cases, because if the pressure is remaining sustainedly high and the visual fields are not very reliable, this is what will point us if there is a progression. The central corneal thickness has a very large bearing on this. Patients who have a lower corneal thickness have a higher chance of progressing to glaucoma. Visual field and RNFL thickness assessments should be done at least 3 times to obtain a proper baseline after eliminating the learning curve in visual fields. There are newer imaging technologies which can be used for earlier diagnosis of onset of glaucoma. Now, how do we decide who will progress or who is more likely to progress? So our studies, a lot of studies, but most importantly, the ocular hypertensive study has given us a few risk factors. So a high initial IOP is the most important risk factor. If there is a family history of glaucoma, a history of vein occlusions, a disc hemorrhage at any examination, high myopia, increasing age at the onset of this raised intraocular pressure, and thin corneas, they are all higher risk factors. And when we find them, we must be more vigilant and follow up the patient more frequently if we are not starting the patient on treatment. Coming to the next type of suspect, if it is a disc suspect, then we first have to look at the disc size. So if there have been acute episodes of angle closure, it could have given rise to disc pallor. But other than that, generally a disc pallor, which is more than cupping, would indicate a pathology other than glaucoma. As you can see here, this is not glaucoma. Here, the cupping is not of worry. It is the pallor which is more worrisome. Same is the case here. If we are looking at an optic nerve head or an RNFL imaging, we have to be sure that we are not over-diagnosing glaucoma. This typically happens when we are imaging the optic nerve head and diagnosing a typically red-colored entire judgment comes as a glaucoma as a diagnosis. However, if we look more carefully, the examination is absolutely improperly done and cannot be taken as a glaucoma. The same holds the other way around. Just based on an OCT finding which highlights everything in green does not mean that we disregard a suspicious disc and we label a disc suspect as a normal patient. Progression of this disease is in fact the absolute diagnosis that this is not a suspect but a case of glaucoma. So all the tests have to be repeated over time when we are labeling a patient as a suspect. Certain software are available, which is known as the glaucoma progression analysis. This helps us both in the visual fields as well as on OCT imaging. Progression analysis has the other advantage that they do not require our normative database. So even discs which are slightly atypical, discs of myopes or discs of tilted discs or racial differences in the discs, all these are obviated. Now, if we have a patient who has a suspicious visual field, again, this has been already covered. So a suspicious visual field in the absence of other clinical findings would not lead to a diagnosis of glaucoma. A thumb rule here is that if the visual field appears suddenly, it is very unlikely to be glaucoma unless there has been an acute episode of angle closure. Generally, in such cases, we have to rule out other conditions like ischemic optic neuropathy. But a visually significant symptom which was noted by the patient some time back may or may not be glaucoma. So that is the reason we require at least 3 visual field assessments in the first year to establish whether the patient is having a progressive defect or not. If the patient has a progressive defect, it automatically goes towards the diagnosis of glaucoma. But if not, then we keep the patient as a suspicious visual field and observe the patient. If there is any unexplained loss in the visual acuity or an unusual type of visual field loss, then we immediately need to think about something else rather than pursuing the diagnosis of glaucoma. So there can be these atypical visual field defects which must not be mislabeled as glaucoma. Now, if we have a patient, here I'm talking about open angle glaucoma suspect. So a patient who has been suspected to have an open angle glaucoma must undergo these investigations thoroughly. So they will include a complete slit lamp examination to exclude secondary glaucomas, a gonioscopy to exclude an angle closure, a proper intraocular pressure measurement at multiple visits, a disc and RNFL evaluation, and an automated perimetry. Based on them, if we get a raised intraocular pressure of more than 22 millimeters of mercury, we must look at the disc. There might be a clear diagnosis of glaucoma or there might be a normal field. Now, if the disc is abnormal, it still becomes a pre-perimetric glaucoma. However, if the disc is normal, the field is normal, and the pressure is raised, we label him as ocular hypertension and may follow up the patient if other risk factors are absent. Coming to a normal intraocular pressure, but with disc changes and visual field changes or visual field changes. In this case, central corneal thickness becomes even more important because if we have a corneal thickness which is less, then we still might have a diagnosis of normal tension because of falsely estimated intraocular pressure, low intraocular pressure. An intraocular pressure which still is higher than 21 mm of Hg and then corresponds to visual field defects will be classified clear-cut as glaucoma. What we need to remember is there is a subset of patients who will not have any of these. And then in that case, we must look at other causes of glaucoma. At the end of it, let us give a case scenario. There is a 50-year-old female who has come for a routine eye checkup and gives a history of her father having suffered from glaucoma. Her intraocular pressures are 24 and 22. The corneal thickness is normal. Disc, visual fields, everything are normal. So we take this case as a case of ocular hypertension and we follow her up. After establishing stable visual fields, we follow her annually. However, on her next visit, she gives a disc hemorrhage here. Now, once there is a disc hemorrhage, she becomes a high risk for developing progression in glaucoma. So now we must look for corresponding RNFL defects for visual field defects, and if so, we must start the patient on treatment. There are also angle suspects which have a narrow angle. This has already been covered quite well by Dr. Deep, so I will not go into details regarding this. So this is the same chart where I shall not be with this, but this is that area where after doing a gonioscopy, you find that the patient has more than 180 degrees of closure of angle. Then that patient becomes an angle closure suspect in case the intraocular pressure and the disc are normal. So patient with angle anomalies or angle recession, these are also the patients which require an annual review with a complete and comprehensive glaucoma evaluation to ensure that the patient is not progressing into glaucoma. To treat or not to treat will depend on a couple of factors. Most importantly, we have to treat it if there is a possibility of the visual field loss, which is more than the expected life expectancy. In the sense, if the patient has a higher life, if it is a 40-year-old male who has ocular hypertension or a suspicious disc, that patient has to be followed up much more closely and probably started on treatment earlier than a patient who is 70 or 80-year-old, who anyway has lesser life expectancy and might have difficulty in putting medication. Treatment-related side effects must be discussed with the patient. Also, what is important is that patients who are at a low risk, but who are very good with complying with regular checkups, can be kept for a follow-up, close follow-up, and not be started on treatment. There are risk calculators which are available. This is just one of them, where the age, intraocular pressure, corneal thickness, the pattern standard deviation on a visual field test, and the cup disc ratio, and many other factors are computed. And then a point-based as well as a continuous calculation of risk is available. These might help us in deciding how closely and how frequently we must follow up our patients. If we do need to start these patients on medication, then in case we are starting a suspect on medication, a prostaglandin analog or a medication which has lesser frequency of instilling of drops might be more beneficial if no contraindications exist. There are other modalities of treatment for these suspects. Most importantly, selective laser trabeculoplasty in case of open angles, clear lens extraction in case of closed angles, and minimally invasive glaucoma surgery. Thank you.
Thank you, Dr. Kushbu. Now, again, I would like to invite Dr. Puneet Singh on his second topic, target intraocular pressure and how to calculate it.
Yes, good morning again. Good morning, everyone.
Good morning.
Let me share my screen. Yes. So the topic for me is targeting intraocular pressure. We all know that target intraocular pressure, glaucoma, and when we treat glaucoma, we treat different risk factors, and the intraocular pressure is the only modifiable and treatable risk factors. So the target IOP may be defined as a pressure, rather it is a range of intraocular pressure within which the progression of glaucoma and visual field loss will be delayed or halted. The goal of clinician while treating glaucoma patients should be to lower the intraocular pressure to that level which is safe for that particular eye. According to Australian Blue Mountain study, they found that the odds ratio of developing glaucoma was 4.7 times higher in the patients, those who had a screening IOP of more than 21 millimeter mercury, than in patients who had a lower IOP. Then, according to the AGIS study, which is Advanced Glaucoma Intervention Study, reducing IOP in glaucoma patients limits disease progression and vision loss. Unlimited reduction in the risk of glaucoma progression, with that important. So, let us say never treat glaucoma based on NCT. NCT can give false reading. So when we talk about when you treat glaucoma, Goldman application tonometer, because 1 millimeter of difference in IOP also will cause 10% reduction in the risk of progression in future. So before we start setting target intraocular pressure, there are certain factors which we need to consider. First and foremost, we need to consider the IOP level at which optic nerve damage has occurred. If the IOP level based on IOP where the damage occurs is on the higher side, we can set a higher target IOP. When the IOP is at the mid-teens, we can set a low target IOP. Then we also need to see the extent and the rate of progression of glaucoma. If the glaucoma is fast progressing, we need to keep it low target IOP, and if the progression is less slow, then we can still set a high target IOP. We also have to look for the other risk factors like presence of family history. Then we need to look for history of high myopia, history of thyrotoxicosis, whether the patient's other eye conditions, if the person has lost the other eye, then you need to be slightly aggressive in setting in terms of target intraocular pressure. Then we need to look for the patient age. If the patient is of older age, then we can set a higher target IOP. If the patient is of young age, and when you diagnose glaucoma at a younger age, then considering the lifespan span of the person, we have to set a lower target IOP. Expected lifespan, if it is on the higher side, then low target IOP, and if the lifespan is less, then you can set a high target IOP. Medical history, if there has a history of diabetes, hypertension, you can still be slightly aggressive and set a low target IOP. Now, what would be the choices of IOP? As we discussed, IOP before treatment, if it is on the higher side, set a high target IOP. If it is on the lower side, set a low target IOP. Then we also need to see the risk factors, like if the cornea is thinner, you have to be slightly aggressive and set a low target IOP. If it is a thicker cornea, you can set a higher target IOP. If the life expectancy is short, like when you diagnose glaucoma at the age of 70, then you can set a higher target IOP, because the life expectancy of that person is not, more compared to when you diagnose a glaucoma at the slightly younger age, where the life expectancy is more. So you need to be slightly aggressive and set a lower target IOP. Then if the damage is more, which is in case of advanced glaucoma, we need to set a low target IOP. And if it is early case of glaucoma where the disc is 0.7 and early central scotoma, you can still set a high target IOP. Now there are different types of clinical trials which have been done in like ocular hypertension treatment trial, EMGT trial, GTS trial, SIGETS and AGES trial, which normally tells us the importance of target intraocular pressure in terms of treatments of glaucoma. So according to ocular hypertension treatment study, when we reduce the IOP by more than equal to 20% from the baseline, the chances of progression from ocular hypertension to PUAG was lesser than the actual. According to SIGET study, the newly diagnosed patients were treated both medically as well as surgically. Both medical treatment and surgical treatment lowered IOP. Surgical treatment lowered IOP more than the medication. And they found that glaucoma progression was minimum in those patients who were treated surgically, though there were some risk factors which were involved in surgical cases. So there are different baseline factors which predict the onset of POAG in case of ocular hypertension treatment trial. If the age was more than 68 and the CCT was thinner, IOP was more than 21. And they also looked after PSD and vertical and horizontal CT ratio. These are the different risk factors which were more in favor of progression from ocular hypertension to POAG. According to EMGT trial, the lowering, the EMGT trial, what they did, they compared the effect of immediate lowering of intraocular pressure versus simple observation, and they found that the patient who were treated, they had lesser progression. And they also found that for every 1 millimeter drop in IOP, there was 10% reduction in the risk of glaucoma progression was observed. So the early treatment reduces and delay the glaucoma progression in case of glaucoma patients. According to the EMGT trial, there are different baseline factors which were there for the progression, IOP more than 21 and presence of pseudo-exfoliation syndrome and age more than 68 years were the most prevalent risk factors. According to the advanced glaucoma intervention study, trabeculectomy versus laser trabeculoplasty, they divided the patient in two arms. One patient underwent trabeculectomy, other patient underwent laser trabeculoplasty. What they found that when the target IOP was less than 18, the progression of glaucoma was minimum. So they divided into three categories. One set of patients where IOP was less than 14, second set of patients where IOP were in between 14 to 75, and the third set of patients where IOP was more than 17.5. So the patient who had IOP of more than 17.5 had more progression than the patient who had IOP of less than 14 millimeter of mercury. According to CNTG's collaborative normal tension glaucoma study, IOP reduction was more with NTG, and those patients who had more than 30% reductions had lesser progression than the patients who were simply kept on observations. So in short, when we diagnose glaucoma, there are certain rules of thumb. When you diagnose a case of ocular hypertension, we have to achieve a 20% from the baseline lowering of the IOP. If you diagnose a case of mild glaucoma, we need to set a target IOP of 18 millimeter mercury. In case of moderate glaucoma, target IOP should be 15. Advanced glaucoma, you can keep a target IOP of 12 millimeter mercury. In case of normal tension glaucoma, IOP reduction by 30% will achieve our purpose. So always remember, target IOP is not a fixed number. When you fix a target IOP of 15, and when you are following the patient and patient is doing good in next 5-6 years, you can still increase the target IOP from 15 to 17, because in terms of achieving target IOP, basically you have to use more medication, which will cause a lot of side effects. So the target IOP which you want to fix, that you should achieve with the minimum medications, with the better safety profile for the patients, as well as we should also look into the pocket of the patient, because if you advise 4-5 medications in terms of achieving target IOP, that is not going to serve the purpose, because 4-5 medications will cause so much of side effects. Patient may stop the medications after a couple of years, and eventually they may come, the glaucoma may progress in future. So how much we need to lower it? There are different society like European Glaucoma Society, Canadian Society, and American Society. They had certain criteria. According to EGS, European Glaucoma Society, mild glaucoma should have IOP of 21 or 20% reductions. Moderate glaucoma 18 or 30% reduction. Severe glaucoma should be 40%. According to Canadian guidelines, it should be again 20 or 20% in case of mild, 30% in case of moderate, and 40% in case of severe glaucoma. Now, when we decide how much should we target IOP, we need to basically categorize the glaucoma into mild, moderate, severe. For that, there are 2 criteria. We need to see the optic disc, cup to disc ratio, neuroretinal rim, and we also need to see for the visual fields. So according to Indian Journal of Ophthalmology, they have different classification based on AO guidelines, Canadian guidelines, and we need to categorize glaucoma into mild, moderate, severe. According to AO guidelines, the mild glaucoma will be having optic disc cupping without any visual field loss. Canadian guidelines says mild glaucoma can have CD ratio of less than 0.6 with visual field loss within 10 degree. Moderate glaucoma falls into CD ratio of 0.7 to 0.8, which visual field loss not within 10 degree. And severe glaucoma, where the CDR is more than 0.9 and visual field loss within 10 degree of fixation. So based on that, we see the first picture where the CDR is 0.6, that falls into early glaucoma. Second picture, which is slightly larger disc, CDR is 0.7, which falls into moderate glaucoma. And third picture, where the CDR is 0.9 with bipolar mode, that falls into severe glaucoma. So if you want to set a target pressure for the first patient, you can set around 18. Second patient, you can set around 15. And third patient, you can set around 12 millimeter mercury based on the optic disc photograph. We also have to see the visual fields. When you do visual fields and when the mean deviation is less than 6, it falls into mild glaucoma. When the mean deviation is between 6 to 12, it falls into moderate glaucoma. And if it is more than 12, it falls into severe glaucoma. So one of the beautiful pictures, this picture was given by Dr. Ramanjit Shihota. We all of us know CJ, author of famous textbook Parson. And what Madam, according to Madam, if you do optic nerve head and perimetry on 2 consecutive reading, which will be reproducible, and if the cup to disc ratio is around 0.6 with the visual field loss, she categorized into early glaucoma, and we need to keep a target pressure of 15 to 17 in case of early glaucoma. If you see the second picture where the disc is 0.6 with inferior notch with the superior arc weight, which is corresponding to the disc finding, see leveled this kind of person is a moderate glaucoma, and the target pressure should be 12 to 15. And third picture where there is a bipolar notch with a biarcuate scotoma with a macular plate, we need to be slightly aggressive and keep our target pressure around 10 to 12. Again, the first picture, mild glaucoma, mean deviation less than 6, target pressure we can keep around 18, moderate glaucoma 15, advanced glaucoma around less than 12. Visual fields of different mild, moderate, severe. Looking at the first visual field, it falls into mild glaucoma where we can keep the target pressure around 18. And that should be reproducible. You should have 2 consecutive visual fields of that particular pattern. Second picture, where you have a visual field involving the inferior arc weight, but not within central 10 degree fixation. It falls into moderate glaucoma, and you can set a target pressure around 15 to 16. The third picture, where there is a visual field which is involving biarcuate scotoma, there is a macular split, so that visual field falls into severe glaucoma, and you need to keep a target pressure around 10 to 12 millimeter of mercury. Again, mean deviation in first perimetry less than 6, mild glaucoma. Second mean deviation 14.7. It falls into severe glaucoma, and the target ratio if you want to calculate for this particular patient, it has to be 10 to 12. So there are different mathematical formulas given in the textbooks. Basically, we don't need to calculate and don't need to waste your time. This is not practically feasible, but just for the sake of knowledge, you should know that modified Jampel formula, where they had a target pressure is equal to initial pressure into 1 minus initial pressure by 100 minus Z plus minus 2, where Z is a different algorithm. Like if Z is 0 when it is a glaucoma suspect, it is 1 glaucoma suspect on the highest category, early glaucoma 2, 3 moderate glaucoma, and 4 for severe glaucoma, 5 for anti-stage glaucoma. Instead of that, this formula is more feasible. Target IOP we should calculate with the maximum IOP minus maximum IOP percentage minus Z, where Z is an optic nerve damage severity factors, and Z also the algebraic value of Z will be 0 when the disc will be normal and the normal visual fields. It will be 1 if the disc is abnormal with the normal visual field. Z will be 2 when the visual field loss which is not involving the fixation and there is no macular split, and Z will be 3 when the visual field loss which is threatening or involving the macular split. So based on this formula, there is a example to how to calculate. Suppose the person who has an IOP of 30 millimeter mercury and the optic nerve damage or visual field loss which is not involving the fixation. So the baseline IOP was 30 minus 30% minus 2, which was the Z. So that will come around 19 millimeter mercury target intraocular pressure. So with this formula, I can still calculate and set a target intraocular pressure. But to be very precise, you should remember mild, moderate, severe based on the optic disc finding and visual fields finding, and try to set a target pressure based on mild, moderate, severe than going for the calculation, and which is not practically feasible in our PG setup. So to take home message for all of us, we are not going to have a one target pressure which is appropriate for every individual. We need to be very flexible for target pressure. It is a dynamic process, and we always have to be alert and open for modification. And patients should be followed closely over time, and their target pressure should be adjusted depending upon how the patient is doing. If they are doing good, they are not progressing, you can increase the target pressure, and if the patient is progressing, you have to reduce and lower the target pressure. Thank you.
Thank you very much for your very informative and interesting talk. Now, our next faculty is Dr. Sachin Mungle, sir. So I would like to invite him to enlighten us with the first talk on a trabecular glaucoma and the second talk on a secondary glaucoma.
Good afternoon, everyone. I'll share my screen. In the interest of time, this is a video of about 3.5 minutes. But before starting, I would like to acknowledge Dr. Ahir sir. He is my first guru in ophthalmology, and I learned a lot from him. Yeah, I hope I'm audible, right? Yeah.
Yes, sir, you are audible.
Yeah. Dr. Ahir sir has taught me, a lot of things, and he was the first one who taught me the steps of, anti-glaucoma surgery. So just taking over, I would like to say that whenever we subject the patient for anti-glaucoma surgery, the first thing we need to know is that what is the diagnosis of the patient. If we know the working diagnosis, it becomes very easy for us to operate that patient. Then we can divide the trabeculectomy into 3 steps basically. The first one is the pre-op stage, the second one is the operative stage, and the third one is the post-operative stage. In the pre-op stage, we should make sure that the conjunctiva is not inflamed. If there is some amount of inflammation, we should start low-dose steroids pre-operatively. Secondly, we need to make sure that before subjecting the patient, the vitreous is shrunken. That is, for that we normally give mannitol in the dose of 5 ml per kg.
Sorry for interruption, sir.
Yeah.
We are seeing the folder only. Have you shared a PPT?
Yeah, you're seeing
Can
the,
you share your entire screen, sir? Because now it's sharing
Yeah,
a
sorry.
only folder.
yeah, just a minute.
Sir, you can stop share screen and then reshare your screen, sir.
Okay, I'll stop share. I'll again share, just a minute.
Still it's coming folder, sir. I think you have shared one particular tab. Can you share your entire screen, sir? While sharing the screen, it will be asked for a bold screen. First option, screen button. Click
Yeah,
on that.
just trying to.
So now click on green share screen button. Then click on first option screen. And then share.
Just give me 2 minutes. I'll need some help for here. Yeah, just a minute. Just a minute.
Yes, sir. Now it's visible.
Yeah. I'll start the video again. Yeah. So coming back. Yeah. Before before subjecting the patient, we should be absolutely sure about why we are operating the patient and what should be the target IOP of the patient. So once we take the patient for surgery, we should make sure that the eye is properly anesthetized. We can either use a peribubble block or a retro block or a subtenance. People do surgeries under topical anesthesia also, but we should be comfortable with whichever method we choose. Uh, the, uh, the other thing is that there are two ways to do a surgery: either a congenital flap, either use a fornix based flap or a limbal based flap. I'm very comfortable doing a fornix based flap. Many people might be comfortable doing a limbal based flap. That's perfectly fine. The other thing is that whenever we take to expose the eye, either we can use a corneal traction suture or a superrectus suture. So once the mitomycin C, we can apply the mitomycin C under the conjunctiva, and it should be diffuse application. The concentration can vary from 0.1 to 0.4, and the time can vary from 1 to 4 minutes. It all depends like what works best in our hands. The other main thing is that mitomycin C should be used um, uh, before opening the globe. It should never be used after opening the globe. Then once the conjunctiva is undermined, a proper cautery is done. We can make a scleral flap. The size of the scleral flap varies from 4 to 5 mm. I make a scleral flap with the 11 number a blade, and for dissection I use a 15 number blade. So we need to make sure that that we are in the same plane while dissecting, and simultaneously we need to keep mopping. So if we are short of assistants, what we can do is we can use a Mirocell sponge, which is which can help mop at the same time. While dissecting, we need to be we need to go inside we, uh, inside the clear cornea. Once that is done, then to make the deep window, the deep scleral window should be smaller than the superficial scleral flap, and the it can be about 2 into 2 mm. it all depends, like, what works best in our hands. The only thing is that, the dissection should be clear cut. So here I'm making a, a marking. So once the deep window is marked, so the other thing is, uh, there should not be sudden decompression of the globe, because sudden decompression of the globe can lead to increased chances of wipeout. Uh, what I'm doing here is making a paracentesis with a 26 gauge needle. This is an old video. I stopped doing paracentesis. Now what I do is I don't make a paracentesis. I directly directly do it from the main wound. So once the paracentesis is done, slowly the deep scleral flap is dissected, copious irrigation is on, and the PI. So there is a PI is very important. Peripheral arectomy is very important over here. We should make sure that the arectomy should be larger than the ostium, because if the arectomy is smaller than the ostium, there is a possibility that the iris might get stuck into the ostium, and the trap can stop functioning. So the PI opening should be larger than the ostium. Once that is done, what I normally do is I take a single apical suture. The single apical suture should be such that it should not be very tight nor very loose. Uh, it should be such that that the ostium is that the fluid is flowing through freely through the ostium, and you should check it with the help of a Murocell sponge. Normally, in most of the cases, I don't use a releasable suture. If only if required, I use releasable sutures, and that too in advanced glaucomas or in juvenile open angle glaucomas. In clear cut cases of open angle glaucomas, angle closure glaucomas, I just take a single apical suture. After this, this is the most important step. Like, we need to suture the conjunctiva. The conjunctiva can be sutured with a 10O nylon, a 10O vicryl, or a 8O vicryl. What I used to, I tried all the sutures, and now what I'm comfortable with is with 80 vicryl. In this video, I'm using a 10O nylon suture. The only thing is that whenever we suture the conjunctiva, the knots should be buried under the conjunctiva. They should not irritate the patient, because if the knots are not buried, what happens is the patient keeps squeezing his eye, and because of the squeezing, it leads to massage effect of the bleb, and the bleb may fail. A good watertight suturing is must. There should be no leak, no conjunctival leak. You can use 2, 3, 4 sutures, whatever is comfortable, but just make sure that there is no that it is a watertight wound. The other thing is many times we can use a suture over here also at the limbus. So so on the first post-op day, there's no leak over here from the limbus. So here I'm just being extra cautious and suturing the wound, the conjunctiva. Once this is done, we can I normally give subconjunctival dexamethasone inferiorly, and just I make sure that that cycloplegics are used liberally, because cycloplegics they pull the iris lens diaphragm backwards and make sure that the AC is well formed. Even if the IOP is low and the AC is formed, then it is a good sign. This is the perimetry report of the patient. The patient, when the patient had presented, the patient had advanced visual field loss with fixation thread, and the perimetry is remaining more or less stable after the anti-glaucoma surgery without medications. The IOP is remaining in the range of 10 to 12 mmHg, which is pretty good. So this is it. So I'll go to the next topic, that is secondary glaucomas. Give me 2 minutes.
Sorry, sir, you are not audible.
Yeah, just a minute. I'm sharing my screen. Yeah.
Okay, sir.
Okay, is the screen visible? No.
No, sir.
Okay. Just give me 1 minute.
Sure, sure. Yes, sir. Now visible.
It's
Your
visible?
skin is
Okay.
visible.
Okay.
Yes, sir.
Yeah. So secondary glaucomas is a broad topic. So normally in a glaucoma OPD, we see about 20 to 25% of all glaucomas which are secondary in nature, and the treatment is varied in case of secondary glaucomas. And if not diagnosed properly, they can lead to rapid visual loss. So we can broadly classify secondary glaucomas into angle closure and open angle. So secondary angle closures are basically, see, I tried to in the interest of time, I tried to add some relevant points in secondary glaucomas. So the most common is the most common secondary angle closure glaucomas are malignant glaucomas, nenophthalmos, neovascular glaucoma, ICE syndrome. Systemic drugs can cause secondary glaucomas with the increase in the number of vitreoretinal surgeries. We tend to see more of secondary angle closure glaucomas after vitreoretinal surgery also, and following keratoplasties we also see secondary angle closure glaucomas. So malignant glaucoma is an aqueous misdirection syndrome where there is axial shallowing of the anterior chamber. These points are very important. There is axial shallowing of the anterior chamber, the IOP is elevated, and to diagnose a malignant glaucoma, the iridotomy should be patent. If the iridotomy is not patent, we need to make sure that that we make a good PI. And there is absence of suprachoroidal fluid in case of malignant glaucoma. The there is rotation of the ciliary body, which causes forward lens movement. So the malignant glaucoma can be seen after cataract, after anti-glaucoma surgery, after combined surgery, and it is normally seen in hyperopic eyes. So the treatment is, we should continue with anti-glaucoma medications, hyperosmotics, mydriatic cycloplegics. That's the most important thing. Atropine needs to be given. A YAG laser hyalotomy works wonder. Whenever after doing combined surgery, or if the eye is pseudophakic, we need to make sure that we break the posterior capsule, or we break the hyaloid phase. And if not, if the IOP is not controlled with these measures, then the patient can be taken for vitrectomy. But in most of the cases, the malignant glaucoma settles down well after a couple of weeks, if the patient is treated with anti-glaucoma medications and with a YAG laser iridotomy. So how to prevent malignant glaucoma? The main thing is to prevent shallowing of anterior chamber. As I told, that tight suturing of the conjunctiva and the scleral flap is a must. Liberal use of mydriatics and cycloplegics is must. Okay. Coming to the secondary angle closure glaucoma, that is nanophthalmos. It's also known as dwarf eye. The ocular volume is is small. The patient is normally high hypermetrop, very shallow anterior chamber. The lens and the ocular volume are disproportionate. The sclera is thicker and disorganized, and nanophthalmic eyes are very difficult to treat. Trust me. The choroid is thickened in these cases. The chances of choroidal effusion and choroid detachment along with RD is very, very high. Conventional glaucoma surgeries have disastrous consequences. So before doing anti-glaucoma surgeries, sclerectomies need to be done in the inferior quadrant. The most important thing is to identify which eyes are nanophthalmic eyes, and then to plan surgeries accordingly. With the longevity increasing and with the number of diabetes increasing, we tend to see this neovascular glaucomas more often. Also, because people have become very aggressive while treating cataracts, we tend to see these neovascular glaucomas. So initially, a fibrovascular membrane grows over the trabecular meshwork. The angle is occluded initially but open, but over gradually the angle closes. Neovascular glaucoma can also be seen after CRVO, ocular ischemic syndrome, BRVO, chronic uveitis, chronic RD, and proliferative diabetic retinopathy. So 1/3 of all CRVOs are ischemic. 16 to 60% of ischemic CRVOs will develop NVI. 20% of PDR will develop NVG, and 18% of CRVOs will develop NVI. So NVGs are very difficult to treat. The first thing we need to do is to make sure that the retina is properly lasered. Anti-glaucoma medications have a role in management in the course of the disease, but the only thing is in active neovascular glaucoma, pilocarpine and prostaglandin are contraindicated. Anti-VEGF is a must, and it should be given intravitreal and not intracameral, because the half-life of anti-VEGF in aqueous is about just couple of days, whereas in the vitreous it is at least about 7 to 14 days. So it should be given intravitreally, and this after AGF and anti-VEGF, it should be followed. If the IOP is not controlled with medications, we need to do a trabeculectomy with mitomycin C, or if the conventional surgery does not work, it can be followed with a MS glaucoma valve. But a trial of TRAB can be given and is successful. So ICE syndrome, we tend to see these ICE syndrome patients very often nowadays. These are unilateral young age females or middle-aged females, and the main thing is that here the peripheral anterior synechia, they extend beyond the Schwalbe's line. Normally, line, whereas here the peripheral anterior synechia extend beyond the Schwalbe's line. Basically, there are three types of ICE syndrome. One is, am I audible?
Yes, sir. You're audible. Please carry on.
Yeah, because the internet is a little bit fluctuating over here. Yeah. Basically, ICE syndrome are of three types. One is essential iris atrophy, second one is Chandler syndrome, and the third one is Cogan-Reese syndrome. In essential iris atrophy, we get to see iris atrophy, correctopia, ectropia, pseudopolychoria. Iris hole formation is a hallmark in case of essential iris atrophy. In Chandler syndrome, there is no iris atrophy. There is correctopia, there is corneal edema. In Cogan-Reese syndrome, we see these nodules on the anterior iris surface. So the treatment is, if the ICE syndrome is extensive, and if the corneal transparency is affected, the patient can undergo a cradleplasty. But before the patient undergoes cradleplasty, we need to make sure that the glaucoma is well controlled. Conventional surgery many times does not work very well. So AGV might be preferred in these cases. So there are, with the number of drugs increasing and with the number of diseases increasing, there are many systemic drugs which cause glaucoma. So these antipsychotics, antidepressants, antihistaminics, anti-Parkinson's, antispasmolytics, mydriatics, sympathomimetics can cause glaucomas. They increase the IOP by angle closure secondary to their anticholinergic properties. Pupillary block from phacomorphic changes or ciliary body rotation. Some of the drugs like promethazine, sulfa drugs, bromocriptine, quinine, metronidazole, or isotretinoin can cause this picture. The most important drug in this category is topiramate, which is one of the favorite drugs of psychiatrists. This is an anti-epileptic drug, which is also used as for migraine prophylaxis, for depression, neuropathic pain, and for pseudotumor cerebri. So this topiramate causes secondary angle closure without pupillary block. 85% of the patients present within 2 weeks of introduction of the drug. The presenting symptom is blurring of vision because of myopic shift. Depending on the IOP, the patient might present with headache, nausea, vomiting, periocular pain. The differentiating feature over here is that this is in case of systemic drugs, the angle closure is normally bilateral. This is a picture. Shall we see? In case of a secondary angle closure because of systemic drugs, the antechamber is uniformly shallow. There is anterior displacement of the lens iris diaphragm. Gonioscopy shows appositional angle closure, and classic iris Bombay pattern is not seen. The pupil is mid-dilated, sluggishly reacting pupil. There might be microcystic corneal edema. On B scan, normally there is 360-degree UV effusion with thickening of the lens and forward displacement of the iris lens diaphragm. The pathogenesis is idiosyncratic breakdown of the blood ocular barrier. The treatment is immediate discontinuation of the drug. Aqueous suppressants, systemic and local, should be given. Topical steroid should be given, and cycloplegics are a must. Cycloplegics, they normally tighten the zonules and displace the iris lens diaphragm posteriorly, making the trabecular meshwork available for aqueous drainage. Pilocarpine is contraindicated as it can aggravate the angle closure by relaxing the zonules. PI is not required because the mechanism of angle closure is not related to pupillary block. Surgical intervention is seldom required in these cases. So the take-home message would be not to rush into treating angle closure with YAG PI in such cases. So Glaucoma after vitreoretinal surgeries is also common. It's mainly because of tight scleral buckle, which leads to occlusion of the vortex veins and leads to evil tract congestion and forward movement of the iris lens diaphragm. The management is again anti-glaucoma medication, cycloplegics, and surgical would be to loosen the tight scleral buckle. Open angle glaucoma is 4 to 12 times higher status for retinal detachment surgeries. It is common in myopes who are on steroids and after inflammation. Schwartz syndrome is again when there is preoperative high IOP, obstruction of the tubular meshock by photoreceptor outer segments from the retinal tear. The condition will improve after surgery. So glaucoma can occur after intravitreal gas also. SF6 gas expands 2 to 2.5 times in 24 to 36 hours, and C3F8 gas expands 3 to 4 times in 3 days. So many times we should be very cautious while using these gases when there is a DM, DM detachment. We need to make sure that the gas is adequately in appropriate concentration. Silicone oil is lighter than aqueous and vitreous and compresses the superior angle in the upright position. Emulsified silicone oil is very dangerous. Immediately, there's 56% of the patients they develop high IOP after silicone oil, and over a period of time, this settles down to about 12 to 30% after 3 years. So to prevent the prophylactic inferior PI should be done. Removal of silicone oil is advocated. Mydriatics and cycloplegics should be used. Steroids can be given. Anti-glaucoma medications need to be used. And in silicone oil glaucoma, trabeculectomy does not work. So in such cases, Ahmed glaucoma valve or oral aqueous drainage implants does work well. Again, coming to glaucoma after keratoplasty. In such cases, applanation tonometry is difficult because the surface is irregular. There is fluorescent pooling around the corneal sutures. It is very difficult to recognize and monitor glaucoma after keratoplasty. The management is complex. 15 to 25% of the patients they present in the first 2 months, and after 3 months, 20 to 35% of the patients might develop high IOP. The incidence is higher in aphakic eyes and eyes after triple procedures. So medical management is successful to a certain extent. The drugs, as we know, are we have limited drugs in glaucoma, and they have their own side effects. So surgical options are again trabeculectomy with or without mitomycin C. If mitomycin C is used, again it might lead to to complication of the graft or to the bleb. So in such cases, valve might work. Coming to the next thing, that is secondary open angle glaucomas. Here we have pseudoexfoliation, pigmentary glaucoma, angle recession, phacolytic, steroid-induced glaucoma, uveitic glaucoma, Posner-Schwarzman syndrome, Fuchs, heterochromic cyclitis, Schwartz syndrome, and increased episcleral venous pressure. Pseudoexfoliation, we are well aware of it. There is deposition of whitish fibrillar material on anterior lens capsule, and in the angle, the zonules are weakened. Normally, these patients present after the age of 50 to 60 years. 50% of the cases they are unilateral, and 50% develop glaucoma throughout lifetime. PXF glaucoma is aggressive. 25% are blind in at least one eye when they present. 7% are blind in both eyes. So here we need to be aggressive with the treatment. Anti-glaucoma surgery with mitomycin C works well, and if there is cataract, a combined surgery can be preferred. Pigment displacement syndrome, with the increase in the number of patients undergoing LASIK, probably the diagnosis of pigment displacement syndrome has also increased. These are young myopic patients who are in the age of 20 to 45 years. 1/3 of pigment displacement syndrome patients they develop pigmentary glaucoma. The characteristic finding is a Krukenberg spindle. which is vertical deposition of pigment on the endothelium. On gonioscopy, there is backward bowing of peripheral iris with heavy pigmentation of trabecular meshwork. On gonioscopy, pigmentary glaucoma can be diagnosed very easily because of the characteristic pigmentation of the trabecular meshwork. So myotics, they reduce the pigment shedding and reduce IOP, but are poorly tolerated, and there is increased risk of retinal detachment. Again, treatment depends on the baseline IOP required in the visual field damage. All anti-glaucoma medication can be used. Surgical option is reserved as a last option in case of pigmentary glaucoma. The good thing about pigmentary glaucoma is that as the age increases, the pigment shedding decreases, and the patient, the severity of the glaucoma keeps decreasing with increasing age. Angulization glaucoma, these are typically unilateral glaucomas where a tear in ciliary body between longitudinal and circular muscles layers can be seen. On gonioscopy, there is irregular widening of the ciliary body band. Angulization glaucoma is seen in 10% in eyes with greater than 180 degrees of damage. So if we can quantify the amount of angle recession, we can keep high risk patients on regular follow up just to make sure that they don't develop angle recession glaucomas. Normally the patient forgets the trauma that has occurred in childhood, and these patients typically present in early 30s or early 40s with gradual dimness of vision. So this angulization glaucoma patient should be followed up indefinitely for the development of glaucoma. Treatment is same as of POAG. Myotics, they make angle recession worse by decreasing the US scleral outflow. Okay, so myotics should not be used. Steroid-induced glaucomas, they increase IOP in 18 to 36% of healthy and up to 46 to 92% of POAG patients within 2 to 4 weeks. May or may not be reversible after cessation of steroid drops. So whenever patient is on steroids, we need to check the IOP regularly. The other thing is that the IOP can increase via all routes of exposure, and more potent steroids cause faster and higher IOP increase. The mechanism is because of the upregulation of myosilin in the trabecular meshwork and accumulation of glycosaminoglycans in the extracellular matrix. Who are the high-risk patients for steroid-induced glaucoma? They are relatives of POAG, angle recession, high myopes with connective tissue disorder patients, and patients having diabetes. So dexamethasone has a very high risk of increasing the IOP. Glucocorticoids cause more IOP rise than mineralocorticoids. So this PSS, that is Poisson-Schwarzman syndrome or hypertensive iridocyclitis, we see quite often in the OPD. The main, the characteristic feature is that these are young to middle-aged adults. Usually, these are unilateral high IOP patients. Recurrent attacks of mild acute anterior-uveitis with disproportionately high IOP. If not properly examined, these patients can be missed out. Here we can see a couple of pigments on the endothelium, but the IOP is disproportionately high. The attacks last from several days to 2 weeks. It can recur at regular intervals. The patient typically presents with blurring of vision. The eye is white and quiet. There might be some corneal epithelial edema, and there are minimal signs of inflammation. The KP is secreting precipitates of small, flat, non-pigmented, concentrated over the inferior endothelium. There might be iris hypochromia. The pupil is often slightly dilated. The gonioscopy feature shows that the angle is open and occasional debris might be present in the inferior angle. So this is a picture. A treatment of choice is a brimonidine is a drug of choice. Steroid should be given in these patients and for a limited time. And the PSS or the hypertensive iridocyclitis, it normally settles down and it is a self-limiting condition. Coming to Fuchs heterochromic cyclitis, again, this is unilateral. Patient presents with with low-grade panuveitis. Heterochromia is seen. Radial vessels can be seen. There is no posterior synechia. Keratic precipitates are distributed over the entire endothelium, and this is out of proportion. It is out of proportion to the inflammation. So FHC is difficult to it's very difficult to control glaucoma. Steroids are not of much use. 2/3 of the patients are resistant to medical management, so they might need anti-glaucoma surgery. Coming to increased episcleral venous pressure, usually unilateral. There is blood in Schlemm's canal. This is because of venous obstruction and some of the AV abnormalities like Sturge-Weber syndrome. So, coming to glaucoma in chemical injuries, acid burn injuries are acid burn injuries can cause shrinkage of outer coats, which can subsequently cause rise in IOP. The alkaline burn injuries causes saponification, resulting in severe damage to the ocular structures. Glaucoma is more often associated with alkali burns. As we discussed, tissue shrinkage involving the outer coats of the eye causes initial IOP spike. The prostaglandin release from the inflammatory cascade causes second hypertensive phase, and blockage of the trabecular with inflammation also causes the IOP rise. Because of the propensity of the burns to cause a rapid and severe IOP elevation, prophylactic treatment with IOP lowering agent should be started. Topical treatment, beta blockers, alpha agonists, and CAI inhibitors. Myotics and prostaglandins are to be avoided because of the inflammatory nature of the condition. So, surgical decision, it's a very difficult decision to take because of corneal damage, because visibility of disc is difficult, perimetry may or may not be possible, and IOP is the only guiding factor. So when to go for surgery? When the IOP is not controlled with all medications, when there is toxicity to the anti-glaucoma medications, and if the patient has to undergo a corneal surgery. Okay. So the take-home message would be, diagnosis is the key to good management. Not all secondary glaucomas require surgery. If at all surgery is required, conventional surgery may not be very successful. There are only 5 to 6 groups of anti-glaucoma medications, and that too they have their own limitations in secondary glaucomas. Okay. Thank you. Thank you very much for patient listening.
Thank you very much, sir. Now we come to our question answer sessions. In this CME, we have our residents also. So this session is open for the all participant.
Hello, am I audible? Hello? 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 Am I audible? Hello?
Yes,
sir. Yes, sir, you are audible.
Yes, please go ahead. Do you have any query?
Yes, sir. I have one query. If we have to perform a trap surgery after SSCS, which incision should be made during SSCS?
Sachin sir, would you like to take?
Yeah. If you have to perform a trabeculectomy after SICS surgery, so
Yes,
which
incision should be made during SSCS?
But no, means you already decided before before operating that the patient might need the trab after SICS, or the patient
planning together, sir.
You're planning the surgery, then why not you go for combined surgery, SICS with trab?
Yes, we are combining the surgery for the first do SSCS, then we will go for trab in the same setup.
So it can be done in the same sitting make a a large V incision as we make in a trabeculectomy. You can then gradually make a corneal tunnel. Okay, and once that the tunnel is made, you can continue the surgery as for SICS.
Okay, sir.
And then you can take a couple of sutures superiorly, and if required, a releasable suture can be taken at the apex or in the side. It all depends like how comfortable
Okay,
you
sir.
are.
So we have to take a square-like flap or a triangular-like a flap.
It again, it all depends like how comfortable you are with. If a square shaped flap can also be preferred, okay, or a triangular flap can also be preferred, okay, but you need to be continue with that. You need to continue with what you are good at, basically, instead of trying too many things at the same time. Okay.
Yes, sir.
Hmm?
Yes, sir.
Yeah.
Thank you.
Yeah.
Thank you so much, sir.
Do we have any more questions from any of our residents?
Yes, sir. Good afternoon.
Yes, good afternoon. Please go ahead. Do you have any more query from one of your residents?
The development of primary open-angle glaucoma.
Sorry?
Dr. Arshi, you are not audible.
My question is, are migraine attacks associated with development of primary open-angle glaucoma?
That is not associated. That is one of the risk factors for glaucoma actually. So we have seen it is kind of one of the risk factors. If some female and those who are having migraine, they can have kind of one of the added risk factors for development of primary open-angle glaucoma.
Okay, sir.
So can I add a point in that?
Yeah, sure, please.
So often what also happens, I feel, is patients who are having subtle angle closure attacks are often misdiagnosed as migraine.
Yes, true.
So that is the other confounding thing which happens. So we are not very sure whether that is migraine, but so a thorough gonioscopy will clear that doubt.
And many times,
yes.
Many times, migraine patient been treated with topiramate, which can lead to secondary angle closure based on bilateral topiramate-induced angle closure, which mostly see in young female.
True. Yes.
Any other query from R3, third year residents?
Thank you, ma'am. Thank you, sir.
Third year residents? Yes.
Sir, my question is.
Yes, Ruchi, go ahead.
Sir, if laser PI is not available in our setup, any chances, then is surgical PI is indicated?
See, surgical PI basically normally the first treatment should be the laser PI. Laser PI, if it's not available in the setup, then try to send the patient to some other setup where people can do laser PI. Surgical PI, we only do once the cornea is very bad, where it is very edematous, we cannot go ahead and we don't have any view, pressure is very high, because while doing surgical PI itself, we can induce cataract. So always better to do PI. If not at your setup, try to send the patient to some other setup. There are so many centers where you can LPI can be performed. But surgical PI, we technically do it only in those cases where laser PI is not indicated. It is contraindicated because of certain conditions, very poor cornea. So that is the take from our side.
Okay, thank you, sir.
Hello.
Yes.
Hello.
Yes, please go ahead.
Sir, Devika here.
Yeah, please carry on.
Sir, in the end, Ahmed glaucoma valve surgery and glaucoma shunt surgeries were discussed. So I have a doubt, like, should we do a shunt surgery when the trabeculectomy has failed, or it is normally like routinely done? Like, what is the difference between trabeculectomy, shunt surgeries? Like, what is the significance, sir?
Yes, Sachin sir, would you like to take? Okay, okay. I think Sachin sir, are you there?
Yeah.
Yes.
Am I audible? Yeah.
Yes, sir.
So, my preference would be,
Yes, sir.
my preference would be that if the conjunctiva is healthy, okay, always go for trabeculectomy first, okay, and if possible, make a do the surgery slightly nasally, so that if you need a second surgery, it can be done slightly superior temporally. Okay. The success rate of first anti-glaucoma surgery, trabeculectomy, is about 85 to 90%. Okay, and the half life of an anti-glaucoma surgery is about 10 to 15 years. So if properly done, and if the patient is on regular follow-up, the surgery would last at least up to 10 to 15 years. Okay, right?
Okay, sir.
After that, if you feel that the IOP is increasing, you might, instead of straight away pushing the patient for second surgery, you can buy your time, put the patient on 1, 2, 3 anti-glaucoma medications also after the first surgery, if the IOP is increasing. Now if you feel that now if the IOP is not decreasing with anti-glaucoma medications and first anti-glaucoma surgery, you can always try for second anti-glaucoma surgery. Okay, again the success rate will go down. For the second anti-glaucoma surgery, the success rate is over 70%. Okay, follow the same routine. If blood needling is required, you might you can consider doing a blood needling in 1 time, 2 times, 3 times. That's okay. Okay, then if at all again the patient needs a surgical intervention, if there is space available, you can try a third anti-glaucoma surgery. The success rate will come down to about 50% for third anti-glaucoma surgery. Okay, if there is no place available, the patient can be posted for a Ahmed valve or a oral aqueous drainage implant. The good thing about Ahmed glaucoma valve is that if because there is a valve mechanism, and the opening, if it is adequate for the tube inside the anterior chamber, then there is no peritubal leakage. Then the AC is well formed, and the IOP is well controlled. But the only thing is that in Ahmed glaucoma valve, the patient needs to be on anti-glaucoma medication, a couple of anti-glaucoma medication, a couple of anti-glaucoma medications. The other thing is that in case of Ahmed glaucoma valve, the patient, there's a ocular hypertensive phase which comes after 3 to 4 weeks. So the patient needs to be a regular follow-up. Many times the ocular hypertensive phase is very violent, so the pressure might not come down after the ocular hypertensive phase. Then at that time you might need to consider a repeat valve or a cyclocryo or a TSCPC. Cyclocryo does not work well, so TSCP, a dialysis TSCPC does work well. Okay, limited. But the only thing is that the diode TSCPC is a destructive form of surgery, should not be preferred in seeing eyes. Yeah, I hope I have covered everything.
Just to
Okay, sir. Thank you, sir.
Just to add, sir, like as Sachin sir said, we always prefer to do trap, because if one trap fails, we can do repeat trap, and the second trap fails, then we can do AGV. But if you do AGV first, that failed, then we cannot do trap. So if you're thinking of AGV, you have a window of doing 3 surgery. Instead of doing AGV first, when you do AGV first, then second trap and third trap, which you could have done earlier, you cannot do. So once AGV fails, as sir was discussing about acute hypertensive phases, and then if the person is having advanced glaucoma where the patient have acute hypertensive phase, they may have a wipeout, they may have loss of vision. And so that the take home message, except silicone oil filled globe, most of the cases, even though it is inflammatory glaucoma, do trap first. Then if it is not working, then go for AGV. Instead of doing AGV first, if that doesn't work, then you have only one option, to go for cyclodiode. That is which we like to add.
Okay, sir. Thank you, sir.
Any other question from our residents or any other participants?
Unmute.
Do you have any other query?
So now we coming to our next vote of thanks. So over to you, Dr. Arushi.
Thank you, ma'am. So with this, we come to the end of this program. Good afternoon, everyone. This is Dr. Arushi Shah, resident Sumandeep of Ophthalmology Department. And I'm here to extend my heartfelt gratitude to all our esteemed guests and attendees on behalf of the Ophthalmology Department, Sumandeep. First of all, faculty, Dr. Hasmukh Ahir sir, Dr. Puneet Singh, Dr. Khushbu Shah, Dr. Paras Dave, Dr. Deep Shah, Dr. Sachin Mungle, for sharing their valuable knowledge on the various aspects of glaucoma. I'm grateful to our chief patron, Dr. Dikshit Shah, and all our patrons and guest invitees for extending their support and being a part of the CME. And lastly, most importantly, I would like to thank those who have been our guides at every step, our teachers, Dr. Hasmukh Ahir sir and Dr. Puneet Singh sir, for making the CME possible. Thank you, respected Ahir sir, for your honorable presence and knowledgeable words. Thank you, respected Puneet sir, for making us understand the fundamentals of glaucoma in the simplest and the best way possible. The CME was a great learning experience. Thanks to you, sir. Lastly, thank you everyone who actively participated and took out their precious time to attend the CME. Hope you all.
So thank you, Arushi. On behalf of Sumandeep, I would like to thank Dr. Sachin sir and Dr. Paraj, Dr. Khushbu, Dr. Deep, who is sparing time on the busy Saturday OPD and contributing and teaching our residents. So we are very thankful to all four of you, and thanks from our team and from Sumandeep.
Can I end the meeting with your permission? Thank you, everyone. So from here, I'm ending this meeting.